the adult and health scrutiny. And thank you for those all online. I hope you can hear me. Can somebody indicate they can hear me? Yeah, online as well. Thumbs up, thank you. I can't hear a thumbs up, but thank you. Lovely job. Good. Okay, as you know, I'm Jill Slocum, the chair of the committee. The agenda pack with papers is available via the ModGov or directly from the council's website from the link which was sent out to members. So I hope that's okay. I'm requesting all members turn off your microphones, videos. Please remember to turn your obviously when we speak, this helps background noise. So if you could do that, that would be great. When I invite you to speak, I'd like you to say your name, please, who you are, for the benefit of people who are listening. We haven't got nameplates in here today. So I'm asking all councillors, would they please, when I point to them, apart from the very important ones, can I point to you, please give me your name. Can I also remind members to just use the chat function solely for committee business, the function, sorry. Otherwise it's distracting. So, you know, as agendas are now viewed electronically, could I request that members and officers refer to the page numbers from the published agenda? Now, there will be a short break in between, and what we'll do is we'll kind of gauge this. I think it will be after item 6, but it may be before. So there will be a little break. So I will try to work that in how long things are going. Okay. So today we have, we're very, very welcome to have Mike Bryant here, who's doing in place of Jamie for the moment. So if you'd like to hand over to you.
Thank you, Chair. We have 2 apologies for today's meeting. Councillor Rosemary Woods will be Councillor Martin Whale is substituting, and we have apologies from Councillor Emily Colston.
Is there anyone else? And there's also Andrew Doverday. Is there any other apologies? No. And thank you, Councillor Whale, for stepping in. Sure. I really appreciate that. Thank you. Item 2 is minutes of the previous meeting. This is to approve the minutes from the previous meeting on the 26th of February. Do I have all your guidance that it's, so you're happy with the minutes? Do we? Oh, Councillor?
Yeah, happy. Yeah.
Thank you. Thank you. Don't forget to tell me your name. So we'll get into this. Declarations of interest, item 3. Do you wish me to sign the minutes? Okay, thank you. This is where members declare any interest and make them aware that the list of committee members' personal interests and members of the district, town and parishes is available for inspection on the website. So if anyone wants to have a look at that. Item 4 is public question time. I believe we have no questions. No public, sorry. No. To see members of the public here if ever they want to come in. Now then, item 5, we have the outcome tracker. This is to advise the committee that there is the first iteration of the committee's outcome tracker, which is designed to support the committee in keeping track of recommendations, agreed agenda items, and queries the committee has. Any amendments or additions, please feedback, and these will be added. Do we have the outcome tracker?
I can share if you'd like, Chair, on the screen.
Yeah, I think it'd be good if we could pop that on the screen. Thank you.
Yeah, it's
Okay, I don't know whether you can. I haven't got the tracker online, so that's a bit of a shame.
It's there as a supplementary.
It is there as a supplementary, but I can't seem to get it for some reason, so I don't know why. Yeah. So if we go down through, actually. Right, so we've got the outcome track. So the meetings are from the 21st of August 25, and it's showing now that one's in red. Provide written reports with data. I think this was the timing from the timescales on community hospitals. So that one is something we're still working on. So that's why that. Oh, I beg your pardon. Thank you so much. Thank you. So as you go down through, you'll see some of them are amber, some of them are in green, and some of them where we've actually managed to do and we're coming back on. So does anybody have any questions? The tracker is new, and I think it's something we'll get used to. Councillor Trimnell.
Thank you, Chair. So there are quite a few of them that are red. Is that because they're things that are coming back to us? Is it things that haven't been actioned yet? Do we know why we have quite a few of them that are red? Because, for example, the green one on the first page, the maternity launch. So we've had that. Is that because we've had that update back, and the other things are going to come back to us?
Thank you, Councillor Trimnell. That's my understanding. This is what this is. The amber ones are ones where they return in 6 months, or we're doing a review on them, reporting back. Can you see the amber ones are where they're coming back?
Yeah.
The green is where we've had them in, and the red is where they're open. These are the open ones. So we want to obviously provide updates on tenancy. We want to provide on the Care Act and the recirculating adult services team roles. These are ones that are what we call live. This is live issues that we want to do. The update on the homeless support we've done. So this keeps us in line in a way with knowing what we want to bring back to the committee, what we want to still talk about. And when we do the action plan, it'll be a way of us referring to this to say, don't forget, we've got this and this, and we bring them back. Some of them we've given dates to, some of them we've explained 6 months, some we haven't. Some we want to go along. So I think that's fairly clear. Is everybody happy with that?
Can I come back? So, for example, where maternity relaunch, and I'm only picking on that because it's just the first one on that page, but they've come back to us. Is that case closed effectively now, or are we still monitoring that?
Well, it says open, so I think we're still monitoring, but maybe Emily will be able to help us. Thank you, Emily.
I'm not too sure I can help you on the maternity one, but I think probably we need to get some clearer time frames on here. I'm not too sure it's particularly clear in terms of the time frames. And I believe in terms of the maternity one, we said to come back, didn't we, in about 6 months. So that probably needs to be reflected within the time frames.
Thank you.
Thank you. So I think the one in green, can we? So I think the one in green, I think that we do want that. We always want the relaunch. The relaunch is something that we've asked to come back. So I don't think that should be in green. So Mike, if you could just make a point of that, please. We need another column, I think. We have got due dates down, to be fair. There are due dates on here. I'm messing up your doctor, I do apologise. We have got due dates that are written on here, but obviously some of them aren't. So I think this needs tightening up, definitely tightening up. And we need another column in here when we want it brought back. Okay? And I think I'll ask for that, Mike, if that's okay. All right? Everybody happy with that? Sarah, are you happy? You're looking worried.
No, I'm just a bit worried about some of the red ones that said a date in October last year, which don't seem to. And I don't know. Were you aware of all these?
Yeah. Can I? Yes, if I can come in there. So the recirculating the adult social care roles, that's been completed. That was done on that day. So I sent that through to Democratic Services. I'm more than happy to send that through again. And the update in terms of the Care Act assessments, that will form part of our performance reports. And there were some amendments that the committee wanted to break it down further in terms of the Care Act assessments and reviews. So that was going to be incorporated into our I think it's 6 monthly quarter of performance reports. So I'm not too sure that those dates are accurate on there.
No, because the dates don't make any sense actually, because it's saying dates on the 10th, and then it's saying open, and then it's saying due by the 17th. Well, we're not going to come back to committee by then, so that doesn't tie up at all. So if we can have a tightening of this, that'd be all right.
Yep.
Thank you very much. Thank you. Oh, sorry.
Thanks, Chair. I'd like to add to that, as well as the having where it's got a red RAG rating, if we could have a little bit more information in terms of why it's red. And that might be a question of putting a note number 1 at the top and then putting some notes underneath if we want to keep the table neat and tidy. But I think we do need some more information on when it's really overdue as to why.
Yeah.
Just a brief explanation that we can then dig into later.
I think Jamie, our Garg is not here, obviously on holiday, and I think he had that information, hasn't been passed on, so I apologise about that. This is a new form of working now with the tracker. So if we can, I certainly will say that, because I would like more information on that as well, okay? I'm crinkly, am I very crinkly?
Yeah.
Don't want to be crinkly,
Unusually crinkly though.
I've been crinkly for years.
Just have that. Can I just speak, please?
So certainly,
I think that probably Helen has put this together and for our feedback, I imagine. And I'm guessing that red means it's past the deadline, you know, and it needs our attention. But as Councillor Bruce said, it's open to interpretation. So there could be a notes column. So I think a couple of ways forward on this is that perhaps we circulate it for people to put the comments that it's relevant to, or we have a note, or we have a notes. But we need to get it right. Yeah, sorry if I'm repeating, but brain cells aren't quite awake yet. But I think it's one of those documents we're always going to be reviewing and catching up and catching things that need updating. So it's going to be a useful tool. But if Helen was here, I'm sure we would probably know a bit more.
I think what we'll do is we'll get that message back to Jamie, because I think it's Jamie that does this. Yeah. Yeah, and what we'll do is we'll get back to Jamie, feedback all this information, and then what we'll do is we'll ask him for the next, what he wants to do with this, because it is supposed to be, he's supposed to give us the oral update, and it is supposed to just be for our attention to know what's there. But obviously this is the second one we've had, and I think it's just not worked as well as we want it to. So we can put that on there for Jamie. That's his homework when he comes back. All right.
Sorry, forgive me. Just a point, it's the point of having the notes in terms of explaining on the columns is important, I think, for us to have it before the meeting rather than having a normal update.
And that would have happened.
Yeah,
that would have
okay.
happened. So as when the agenda is sent out, we want that on there when the agenda is sent out. Is that all right? Thank you very much for that. Thank you. Okay, we're now moving on to item 6, which is NHS Somerset Integrated Care Board. As we all know, this is called the ICB Restructuring Update Report. I'd like to welcome representatives of other agencies and thank them for their time to support this committee's decision today. The purpose of this is to advise members. The purpose of the item is to update on the organisational change programme to merge NHS Bath and North East Somerset, Swindon and Wiltshire, NHS Dorset and NHS Somerset into a single ICB over the next 18 months. Now, I know members will be very anxious, and I know they have expressed that angst about this. So David McClay is to present. I believe he's online. No, sorry, David. Sorry, David. I'm so sorry. I knew there was somebody on this who's going to be online. So David, I would like you to present, please, and then allow, and I will invite members to ask questions afterwards. Thank you.
Thank you, Chair, and good morning, everyone. I'm the Place Director within the Integrated Care Board. The purpose of bringing paper today was to brief members on the change, so a bit of the what and the why, and also then a conversation about that impact at a local level and some of the opportunities and risks that we're managing as we're moving through it. I wasn't going to go through the slides sort of slavishly, slide by slide. I'm just going to pull out some key points and why. Time for questions and answers really, and for
if you could just tell us the page you're on when you're.
Yeah, sure. Yeah, I'm on the deck itself. I think we're going to move through them on the screen if that's helpful as well, Chair. So just a bit of a context. NHS Somerset, is a commissioning organisation, so we receive funding from the government, and we distribute that to local providers and with contracts attached to that to achieve national standards. This change announced last year was it's twofold really. It's got two sides to it. One is to try and create better and stronger and more robust commissioning arrangements across the country in order to enable the shift to prevention and the shift to care closer to home. That's been something that's been discussed in health for the last 20-25 years. It's achieved in part, but not at the pace that we need moving forward. So that kind of there's a big drive to be what's been termed strategic commissioning. And that's one aspect of it. I'll touch on that, what that means today. The second aspect is that we had to reduce our operating costs by 50%, 50, within the sort of starting from the 1st of April this year. So we've got a challenge to try and bring three organisations together, three former ICBs into one, and Cluster ICB. Legally, those three organisations will exist in form for the next 12 months, but in a practical way, we'll be bringing the teams together at the moment, so I'll touch on that. So the first couple of slides is kind of context and sort of the geography of it. So that's the sort of size and scale of the organisations and the scope of the new organisation. So covered right from Swindon right through to Minehead, right down to Bournemouth is the geography. And the intent really is, given that size and scale, is to be able to leverage some of the kind of commissioning opportunities that we've got. I'll come on and talk about that in a second. So a little bit of kind of, I guess, some numbers then on the slide that's in front of you, which is sort of coverage of about 2.5 million people. And it is now got responsibility for commissioning those organisations on the right-hand side. So there's a huge number of primary care services. The acute services generally across the patch have consolidated over the last number of years. So we've got a very good integrated provider locally. We've got also kind of acute providers in BSWs and some integrated providers in Dorset as well. So that's just a bit of orientation in terms of the scope of that new organisation itself. The next slide talks about the finances and just gives a bit of a thumbnail sketch on how we allocate funding at the minute. There's still quite a lot of spend in health on the acute side of things, so that's sort of top right-hand segment. And clearly the big drive for us is to try and meet people's needs further upstream, to try and prevent them getting ill in the first place, and then also in the area to try and treat them in the most efficient way. So hopefully over time, the strategic intent is to try and spend more of that donut, if you like, on the primary care elements of it and on the community care elements of it, and increasingly proportionally less on the acute interventions over time. And that's the aim. And getting to kind of a bigger organisation that's got that leverage and that strategic commissioning capability is key for that. So as I say, this is one of the range of changes that were announced alongside the 10-year plan. So the 10-year plan outlined, the next slide, it's got those 3 shifts. I wasn't going to go into those today in detail, but it is a key enabler for that. We've also got changes to the regional team, and it's a single regional team, where we're going through a sort of a reconfiguration themselves. That's just commenced. And as members might be aware, the NHS England itself will move into the Department of Health, so they will become civil servants as the other big change. So it's quite unprecedented change, I would say, within health at every level. And the key thing is around what that will drive at a local level. So kind of, as I say, the role and purpose of that is to try and, certainly the ICB, is to try and focus more on outcomes, so taking public health data and the insight that we've got and turning that into outcomes for the population, and taking a longer term view on that as well. At the minute, there's quite a lot of focus on the volume of people, the waiting lists, the waiting times, and clearly there's still needs to be focus on that. But we probably spend less of our time at the minute focusing on longer term outcomes, experience, and whether services meet the needs of people and whether we are keeping people healthier for longer. So that's the focus and the deliberate attempt to shift that balance in this new organisation. So a better use of data to drive insight, better use of economic analysis to sort of inform options. And also then sort of a tighter grip really on the contractual arrangements and ensuring that providers can deliver what they say they're delivering. The other bit there is at a local level. Clearly, we are also on a course of trying to bring providers together, so encourage providers to collaborate at a local level in neighbourhoods. And locally, we're forming those around populations around the current primary care network footprints. And the ICB role moving forward is to try and set the outcomes that those neighbourhoods then would work towards, and agree that locally with local people. So that's because the number of different shifts that this change enables, and the big challenge within it, and just gone through onto in the slide deck itself, that's page 33 on the public board plan. Then we've got sort of a job to do moving from where we are now to that new organisation. So it's not just about bringing 3 organisations together, it's about trying to create a new organisation that can do what I've just outlined. So it's quite a different shift. But we have got to reduce our operating costs, and that clearly is a huge challenge. That's sort of, I guess, more detailed terms, that's moving from an employment of about 1,100 people to about 500, just over 500 people, which clearly is massively upsetting for everyone. But that process has now commenced about 3 weeks ago, and we're now in sort of formal consultation with teams around that new structure and that new ways of working. We're receiving feedback as we go through that. That process should conclude at the end of this month, We've got a period of a month then to do version 2 in the final version. And then there'll be a period of a couple of months then to move people into the new focuses. So it's usually that's, I guess, kind of inward looking time for the ICB. We're trying to maintain as much commissioning business as usual as we can during that time, but clearly there's a big internal reorganisation to deliver on. So the rest of the slides just kind of, I guess, give the context which I've outlined. There's a bit of detail on page 36 of the pack, which gives an outline then of what the shape of the new organisation will be. So there'll be quite a strong central team that do commissioning the cycle of things. So looking at needs, understanding how those needs can be better met by providers locally. And also then discharging our corporate responsibilities and statutory functions. So continuing healthcare, infection control, safeguarding, etc. So those statutory functions remain. There's very little change in those as we move into this new organisation. That will be supplemented then by sort of place-based teams, and those places are co-terminus with council boundaries. So Somerset will continue to be one place. Swindon and Wiltshire, and then the Dorset patch is split into 2 council areas as well. So that's kind of the current configuration. We're mindful that there's conversations about strategic authorities and how that plays out, particularly affecting the Baines element, the Swindon element. And those conversations are ongoing at the minute. But we'll have effectively 6 places which will be the local presence of commissioning. And that will be seeking through its convening our ability to encourage providers to work together to deliver the needs that are identified through public health and through our outcomes framework. So that's a bit of a thumbnail sketch of kind of what we're seeking to achieve. There's detail within the pack about what that place-based team looks like in terms of the focus on that primary care commissioning and also developing neighbourhood teams. So I'm happy to talk more about that. And then also then just gives a bit of an overview of the people then that are in part of the exec team in the new organisation. So I guess the key takeaways really are, let's say there's 2 changes here. One is the reduction, the 50% reduction in operating cost, and us having to meet a very similar need, to be quite honest, within a much reduced budget and having to work at scale in order to do that. And the second is taking that opportunity to shift our focus and commission in a way that does enable us to focus more on long-term outcomes and allow providers to collaborate together with local communities through neighbourhood teams moving forward. So there's a number of different changes sort of playing into this. It's not one change in itself, which makes it quite complicated, but I'm happy to kind of take any questions, reflections or concerns. Thank you, Chair.
Thank you. Yeah. Just to, first of all, I just wanted to say thank you very much, David. I think that this is a very complicated system. I wonder what came first, the reduction or the reorganisation. Are you playing one for the other, or was it going to happen anyway? And I often wonder, it's been asked to me why is everything bigger always supposed to be better? There's a real fear that in certain areas of Somerset, especially, the needs of people is not the same as everywhere else. Different parts of Somerset has different needs. And it's a really concern to me that with the greatest respect, the ICB seems very top heavy, there's very lot of administration, a lot of organisation, but I'm not sure if it's getting down to the front line. And that's the worrying thing. And I think we've all noticed how bad things are. And we've got this sort of, with greatest respect, kingdom, but I'm not sure if it's filtering right down. But I'm very happy to listen to other members while I'll come back to you if I may. That's the trend.
Thank you, Chair. So I noticed that it says that we've got the ICB budget. It's going to be about 7.8 billion for this single one. And I wondered whether, considering our age demographic, rurality and things like that, is that our fair share? So it's about £3,000 per person. If we were to go to London or to somewhere else in the country, we're going to find that they're getting more money per head. Is something, because we know that in public health, for example, we know that we don't get as much as other areas in the country. And is this going to be another example of sort of filtering less money to less important areas? We have a very ageing population here. We know that it's a key place to retire to. And so, you know, that complicates things. So are we getting our fair share of the spend, of the total spend? I think it said 100 billion overall for all of the ICBs in the country. So does that represent a fair share? Obviously, we're going from this local system in Somerset where the ICB and the county matched one another, and so the focus was on everything, including Musgrave and Yeovil District Hospital, which are our big hospitals. But now we're going to be competing with hospitals in Swindon, in Salisbury, Bath, teaching hospitals, university teaching hospitals rather than perhaps more outpost type hospitals. And so I wonder whether that is going to make it even hard for us in some of these small hospitals to attract the specialists that we need, because we know that we're losing services such as stroke services. Is that going to become more of a thing as the ICB says, well, actually, the Yeovil District Hospital, we've already lost that. So probably is that going to be an end result, or are you going to be protecting some of our smaller areas, our smaller hospitals and our smaller facilities, please? Because it's obviously cost cutting is the main driver for this.
I come back on the second point of time. So just taking the first point around fair share. So there's been, we've presented to the Health and Wellbeing Board, there's concerns about, I guess, the funding that is within Somerset at the minute and what that does relative to other areas that we're joining with. So certainly the funding for NHS Somerset is a national formula which allocates funding out to ICBs. That approach will continue for 26-27. So there still will be a funding envelope provided to Somerset for the year that we're in. And what this does do is it gives us an ability then moving forward to start to be able to understand the population need more as we progress and understand the value that 7.8 billion is providing at a local level. So there's certainly no changes nationally to the funding formula, to be clear on that. There's no kind of positioning today on we will sort of allocate finances differently, but we will certainly, the intent of the organisation is to have a better feel for where health inequalities are, where the funding is adding value, and being able to kind of look at that right across that cluster. But there's no intent to change the funding formula at present. The piece around, I guess, concerns about kind of hospital services and small hospitals. I think that's it. That is a conversation to be had. We've got alongside of this, there's potential contract models, without getting into too much detail. But some of those large providers, some of the large acutes will move towards advanced foundation trusts, they're termed, and they've got an ability then to take on some of the law commissioning budgets to themselves. And there's different other providers that could do that moving forward. So kind of how that plays into then kind of the ability of those trusts to maintain services, etc., still to be worked through. It does start to provide, and I know stroke is a contentious topic, but it does start to enable us to look and see where the services are vulnerable and in terms of the staffing and sustainability of the staffing model, and that was at the heart of the stroke reconfiguration. But that will be it's not necessarily as a result of these changes that we'll start to get into more of that, but it will be part of the conversation about, okay, well, how do you provide services that are accessible to people, and what do people want in terms of that service design. But there's increasingly a challenge about staffing and services right across the county, and that's what the acute providers that's the risk and the opportunity that they pick up on a kind of day by day, week by week basis. So there's no intent to do more of that, as what I'm saying, but inevitably it is part and parcel of medicine becoming more specialised and being provided in fewer sectors of care.
I just come back very quickly. Will there be people fighting for our more localised services to do all that they can to prevent our smaller hospitals, but us having to then go to Bath or the bigger centres, given the rurality, the lack of public transport and things? Will there be people fighting our case or not?
I've been concerned. Taking the package of changes, the intent is that sort of we've got greater coordination of care through neighbourhood teams, and through that then defining what we mean by neighbourhood health centre and what services are that the people want locally through those neighbourhood health centres. So that's a big government drive around that. And we're saying then, clearly we want to commission in a way that's in touch with what the public want locally as well. So it's not trying to do things out with what the public require. What we can't do is provide, a kind of a specialist unit in every single village across the county. There's always a debate around that scale of services there, to be fair, and sometimes we don't necessarily agree on what that looks like. And that still will be a debate moving forward because medicine is becoming more and more specialised, as you said, and therefore you do need to, increasingly the standards are increasing, and that's what's driving kind of the centralisation of some services into larger providers. But we've got to take the public on that journey with us, in terms of understanding the trade-offs on that, and indeed the kind of the conversation really is broader about what sort of social driving, what other prevention models can be provided in local neighbourhood health centres, and to the what that I want that, and that's kind of the key part of what we're trying to build in moving forward. So although it kind of the organisation itself is getting bigger, we're mindful that there's neighbourhood teams and indeed local providers should strengthen their engagement with the public to sort of design services that they want. But there's always a trade-off, as I said, around what's possible to provide, what's affordable to provide versus what people feel that they should be accessible locally.
Before I go to the next speaker, I just wanted to ask you a question. This gone to consultation, per se?
So yeah, it's internal consultation, just to clear staff consultation about the change, yes.
So it is internal consultation. There's nothing external at all for users or people that want to have their say.
Not for this change.
It's very unfortunate, isn't it? Okay, Councillor, sorry.
It's funny you should say that, Jill. Thank you for coming. This is big news. But we knew this was coming, didn't we? I get the government's rationale with this, but there's a lot on your shoulders as a body and as an organisation when you look at the top line of what you've got to deliver, and then you've got to deliver the change at the same time as the cuts. Does that sound familiar? You know, we've been through the unitary experience, and it is really, really challenging. So I do feel empathy really for you and for your colleagues and for the organisation. But I think the chair's just touched on something. So I just got two points and questions. Prevention is a word we use at the unitary. We prefer another word, don't we, than prevention, but we know the meaning of it, you know, so empowering our communities, building resilience, building strong communities. So my first question is, I love how you have explained your way the services and the costs are, mental health and community health services. So my direct feedback is, why does mental health services should be part of community health service or part of, it shouldn't necessarily be a little box on its own. It's so important. It will help prevention and community resilience and costs. And there is a real economic argument, and there's a lot out there, there's a lot of debate, there's a lot of academia around that. So first feedback is mental health services doesn't seem like it's enough. If one of your goals is to, encourage prevention. So that's my first feedback. Second feedback is what the chairs quite rightly say, it's the communication to the communities. I think all of us on the Scrutiny Committee have a duty now to really get the messages out there to our communities about the changes, about the role you play in everybody's lives as an organisation. And you did say the word we're inward looking, you know, at the moment, but I think there has been a sense of being a bit inward looking as an organisation. I don't want that to sound harsh or anything like that. So the second question is, what communication is going to be done to let the people know that you're serving and your very eloquent top level goals that your first slide has, you know, deliver a health service that's fit for the future, improve the outcomes that matter most to people. Well, what matters most to people is really knowing who you are as an organisation and how this is going to be delivered. And as I say, my caveat is I have absolute empathy with the position you're in with change, cuts, but still having to deliver what you did before. So mental health, there should be more funding for that, and it should, and secondly, communication to our residents about this change and what the impact will mean to them. Thank you.
Thank you for that. Thanks for your words of support, Councillor Scully. We've got the way that's a helpful slide because I think it summarises the way commissioning looks at things at the minute, which is around acute services, mental health, community, primary care. But that's not how people receive care, and that's, you know, if we were to bring that sort of image back in a couple of years' time, it should look more around, okay, kind of more from a population point of view, more people, what package of support do people need. So I think we'd all have views that if we get into trying to keep people healthier for longer and trying to focus on what the population needs are and trying to wrap care more around their needs rather than them shopping around different services trying to get support, which works well for some people but not everybody at the moment, then I think inevitably we'll end up spending more on mental health and support on that, and indeed on the sort of more primary care elements of things. So hopefully in the change that we're making, and I get in terms of the kind of, I guess, the concern over the bigger footprint, I totally understand that, but the change that we're seeking to make is to be more population focused and more around the journey of individuals and cohorts of the population who've got similar needs. And to be then being able to commission services and contract providers to provide that. So that's that is the intent. The second part then about the kind of communication, clearly say there's internal focus at the minute around the organisational change piece. But yeah, I'm happy to pick up how it's strengthened our communication out to the public as part of this. And it's in many ways, it's taken alongside the changes to providers. I think that would be helpful, potentially more meaningful for the public around what those providers might be able to do moving forward and how they'll work together in a different way. I think taking both of those together should be quite, I guess, hopefully reassuring to people rather than concerning.
Thank you. Thank you, David. Can I go to Councillor Cameron?
Chair, Ewan Cameron, I'm the councillor for Glastonbury. David, thanks for coming down today. Really kind to spend what little time you have, because I can only imagine going through such a large reorganisation. It's a concern. I've got one concern, two questions, and one offer, if I may, and if I'm allowed to, just keep it really short. The concern. We know that the 10-year plan was published back in July of last year. By my calculation, we're going to be using 20% of that 10-year plan on reorganisation activities within the ICB. And that just seems slightly out of kilter with what we're trying to do in the delivery of the 10-year plan. I won't go any further on that. It's just that's the concern. Somerset as a place, I'm really enthused about that. And the first question on that is, how are you going to ensure that some of the strategies we're going to be talking about later on today, so for instance, adult social care strategy, the housing workforce strategy, public health strategy, housing development strategy, are truly nested within the place strategy that you come up with in due course? I know you're not there yet, but I would really like to see all of the council-led health prevention messages and strategies are fully nested within the ICB one. And I think those of us who've worked in the NHS have seen in the past that sometimes those have been slightly dislocated. But I would really welcome working with you to find out how that's done. So that's the first question. And then the second question is around the development of services. And I fully understand that the majority of our elective services should not be being conducted in acute providers. So some of the concerns that other councillors have expressed with regard to hospital-based services, I don't necessarily have that concern. The concern I do have, however, is we do have certain places within Somerset, as Sarah Dyke, the MP for Somerton and Glastonbury, mentioned in House of Parliament, we have dental deserts. And equally, we have mental health and drug and alcohol deserts, specifically in Glastonbury. So the second question is, how are we going to make certain that those deserts are no longer, well, turn into oases, if I'm allowed to extend the metaphor? And then the final offer is, please come down to Glastonbury and I'll show you around. Thank you, Chair.
And I know Councillor Ewan always gets him come to Glastonbury. It's like, I think he's a tour operator, to be honest, I really do. But over to you, David.
Yeah, no, thank you for that. Thanks for the kind offer to come down, so I'll take you up on. Yes, they're kind of spending the first 20% of the time period reorganizing and getting things right. I accept it feels generous, but it does feel also quite necessary in many ways. As things layer up over the time, and it's I think the observation and reflection from the centre that it's quite difficult to get stuff done with the current configuration, the way things are. So although it is a kind of some ways a kind of distraction from the here and now, but it does feel to get quite overdue in terms of being able to reset things. Also feel like commissioning has been a bit of a Cinderella service within the health service for quite some time, which you'll be aware of. And it's now feeling that it's getting due sort of attention and focus, and hopefully resource will go with that. In terms of the two areas, yeah, we've got there's a challenge in all of this, which is to try and identify those things that will add value, add benefit, and being able to kind of progress cluster wide and using that scale. Yet at the same time ensuring that any plans that are produced dovetail and are synced with the plans that we've got at a place level. So within Somerset, that's an ongoing conversation that Alison and I and others have, and particularly through the Somerset board, which is our health and wellbeing board. But I take the point on that, absolutely, and that's a challenge. We kind of accept that it's going to have to work at a local level, because that's where it's real and where folk access care and support. In terms of the dental deserts and drug and alcohol, yeah, totally agree with the fact that some of the coverage at the minute isn't where we want it to be, particularly around dental. And I take your point around glass to be the drug and alcohol. I guess there's an opportunity. One, is there a kind of operating at scale around sort of dental providers and trying to sort of encourage the market and entrance to that. There's quite sort of innovative approaches in other areas of the cluster we're picking up already, around trying to solve some of the dental supply issues in terms of capacity. So there might be some elements of learning that we can bring in, that's what I'm saying, maybe from some of the approaches we've got in Swindon at the minute. So there might be good things that can be transferred in. So there's a lot of stuff happening in Somerset that would be applicable and well played elsewhere. And I think the other bit is then, as we touched on just before the meeting, whilst we'll talk about Somerset and the place, increasingly we want to turn our attention to what we're terming neighbourhoods. So it's kind of the PCN footprints, and that's where it gets even more important. So kind of the priorities then of Glastonbury within a West Bend approach would be there'd be an opportunity as we develop that plan. And it's not really about a plan for the sake of creating a plan. It's around having a plan for action in each of these areas that then collectively across statutory organisations we can get together around, and also then with the BCFSC sector and others. So it's about then trying to get increasingly closer to the population, understand the data and what the feedback from our local population is, working with the likes of yourself to say, listen, this is how it's feeling for me and what I'm picking up, as well as local MPs, and then being say, okay, well, listen, here's what we need to do, what's the action we need to take in these areas, and by working together, it won't just be about that, it is the minute largely about kind of healthcare delivery and organising that better. It will be about the wider determinants and prevention and access to exercise, and have you focus on that. So kind of it's easier to say that, isn't it? We've been set up for quite some time, but it feels when you put the different bits of the jigsaw together, not just the ICB changes, we should be in a better place to do that as this year progresses and we get the different plans developed. Thank you.
I will allow members to come back after it's okay, because I'm sure this is a ongoing debate that we all of us want to get into. Can I, Councillor Cara, I'm sorry.
Councillor Cara Strong from
Strong,
Division.
Strong, I couldn't remember the word, but I knew it. Sorry.
As usual, when it comes to me, most of my questions have already been answered. But my concern is what modelling has been done to assess the impact of the merger on access to services for the rural areas. So in West Somerset, you can already feel like you're at the end of the road. So I just wondered what's been done there and how we'll be monitoring the improvements after the restructuring. So I think you've kind of touched on that already.
Well, thank you for that. It's in the ICB, the commissioning changes shouldn't necessarily immediately impact service provision. That makes sense, and we'll still have to we should have greater insight and feedback from the public to understand exactly the challenges in the more rural areas. I mean, we've got a feel for that at the minute, from some of that point of view. So there shouldn't be changes. Come back to your point earlier about kind of the public consultation. It should be then we're in a better position to try and understand the things and meet those needs in a way, rather than any sort of immediate impact to the public, sort of straight off. Probably kind of might add to that.
David, just before I go to the next speaker, I didn't get my question answered because I didn't allow it. So I'm sorry, we went on to something else. But I do find it very difficult to explain to people that they're going to get a better service, and with the greatest respect, it's lovely words. It's all about efficiency, it's all about better service, it's all about across the board, and yet we're actually telling people, but you're not going to get as much money. How do you equate that? How do you, I mean, did you start this because of the money? Because of the budget, or did you start this because you actually thought we weren't efficient enough and we need to do a better job?
So, certainly there's a central decision around the 50% reduction. It's 50% reduction in the operating costs of the organisation. If that makes sense. So it's not any, it shouldn't be any impact on the ICB changes on service provision. There's no reduction in the spend on service provision across any of the current ICBs across the piece. Just to be really clear on that, the 50% was to the kind of operating budget of the ICB itself, and therefore the challenge has been how do you then do those two things that I've spoken about? How do you reset the organisation so that it's stronger at commission, but also then within a reduced sort of financial envelope? So we've got to run the company, if you like, the ICB itself. We've got to run that for 50% less than what it is at the minute. That then took you into, well, Somerset as an ICB was one of the smallest in the country going into this. It then becomes very difficult to do it just focused on Somerset as an ICB, and that took you into conversations about cost of working with the other two ICBs, and that was the sequencing of the steps. The kind of, as I said, the two things came at once: the change in role and the focus on commissioning, and then the fact you've got a reduction in your operating cost of your organisation. So there's no, and just to repeat then, there's no reduction in the financial spend for services provision. It is just the sort of the operating costs, and it's the heads and the buildings that we occupy as an organisation itself.
So it's like efficiencies. We're looking for better efficiencies as well.
Efficiencies within the organisation, yes, that's correct. And that
Thank you for that. David, that's really helped a lot, because I think a lot of people, the trouble is, you know what you're talking about, but unfortunately we assume that it's going to filter down to the members of the public. So that's really good that you've explained that. So you're kind of cutting the admin in a sense more efficiently to make that a better, so that we can carry on with providing a good service. Yeah. And that's really important. And I just wanted to make sure everybody understood that. Apologies, I didn't. So thank you very much. Can I now go to Councillor Bruce?
Thank you, Chair. Yeah, Councillor Hilary Bruce. I just wanted to make sure I've understood correctly. So you're at the start of this journey now, and you say you've got 18 months to make this change. So the cluster in place that you've described in the presentation, that's how you're going to operate at the moment? Or is that how you're intending to operate once it's finished? This is just the start of it and it's all going to change. Are you still going to have place directors at the end of the 18 months? So that's the first kind of question, just to clarify for me that I'm understanding correctly. And then I wanted to check, how does Somerset Council feed into this process? If the consultation is internal, how does Somerset Council have a voice in it? Is this the only place that we will be able to provide input through scrutiny? Or are you engaging with adult social care? Are you engaging with the lead member? And as far as I know, on the ICB at the moment, there is only the chief executive of Somerset Council, who's not even there representing Somerset Council. So I'm just curious to know how we can be involved. And forgive me, Chair, if I go on with the third point. Is there currently existing a roadmap in your minds as to how this change is going to happen? Or is it very much an evolving process? And how often will we be informed at scrutiny of where you are in the roadmap and what's changed and what the next steps are going to be? Thank you.
Thank you. That's excellent. Thank you.
Yeah, thanks for asking that, because it is, as I said before, quite complicated. So we have done the exec level of the organisation, so that change has happened, and that's created the place director, and it would be in post for the longer term, like part of the new organisation, as it were. We are out to consult at the minute then with the rest of the organisation. That's the sort of the other 1,000 people that are in there. So, and that's the one that concludes in the summer. So we are at the minute sort of migrating between the two. So technically the 3 ITBs will exist on paper through the next year, but we'll increasingly have committees in common between the 3. So there'll be a kind of a year of bringing the 3 organisations together into the new organisation. So kind of that's where we're at in the people process side of it. And I guess that will be a kind of year of transition in many ways as we then get through to where we now kind of would be April 27, then would be the start of the new organisation as legal form. That's all has to do with the legislation needed in order to bring the organisations together. So that's kind of in terms of that where we're at. The bit around the links with Somerset Council, there's various touch points that we've got at the moment, either formally or informally. We've obviously got the ICB board and just the chief executive, but also Alton as director of public health as sits on that board as well. And we've got kind of proposal around new cluster wide board, which has got council representation on that. And that's been that will be stood up in sort of April, May, so this month, the next month is when that's going into being. So there's a whole different piece around the governance side of things. In terms of touch points into the council, we've had we're briefing to the Somerset board, which is the health and wellbeing board. We picked up there through kind of making sure we're clear on safeguarding provision, the statutory responsibilities, and how that sort of what capacity we've got in certain areas between the 2 organisations, and making sure we're assured of ourselves around that. So that's part of a live conversation at the minute. So I'm very happy in terms of that roadmap to bring back updates as per what the committee wants to see on kind of how we progress over the next year as part of that implementation.
So the touch points within the council are officer level. We're not talking about democratic touch points with.
We certainly we've briefed the health and wellbeing board, which the leader of the council chairs, and we've got Scott elected members on there. So yeah, so we've got both here on the health and wellbeing board and the 2 touch points we've got.
I think going on from what Councillor Bruce has said, I think we want to be part of this roadmap.
Yeah.
I think going to the health and wellbeing board, we often don't get privy to, because we're scrutinising what's gone through or what's going through. Hopefully it's when it's going through, not when it's gone. But we want to be part of this roadmap. It's essential that we are the front runners, and scrutiny can often be seen as not, but I want it to be. This is a really important points for us, and we want to really keep with you. So at the time when you're briefing health and wellbeing, we also want to see you and Alison, and to be able to come in here and be able to answer these questions, because they will be ongoing. And as time, because when you're doing efficiencies, when you're saving money, you're also worried about the delivery. You say it doesn't affect, but it will affect the delivery. Eventually, it all filters down. That's what we're concerned about, the delivery of the service. With this massive savings, we want to ensure that the delivery remains better than what it is now. And that's really the purpose of our scrutiny. We want it better. Okay, thank you. Councillor Tom.
Chair. I've got quite a few concerns, but I'm not going to list them all now, because actually quite a few of them have been answered by the members. The car on that. And when you're some of the last ones to be selected, you do get a lot of your answers covered. But I'm actually going to touch on a point that I think Councillor Cameron said about the 10-year plan. You know, you're coming to us as committee, and I completely agree with what Jill's just said. I think we should be involved, because obviously you're not going out for a public consultation, which I think is quite shocking actually, because I think every single resident in this area that's actually being changed should have a say on where their healthcare is going and what's going to happen to it. But to going on the 10-year plan that you were going on about, how confident do you, coming to us, because you're sort of selling this to us as members, how confident do you feel you're going to hit your targets with the plan that you've got coming forward within the next 10 years? Thank you.
To the wider plan around 10-year health plan delivery, yeah. So there's a number of different strands to that. There's been and there's still a need to have a clear implementation plan for that 10-year plan. So there's not a a clear implementation plan at the minute. There's different things that are coming into play, such as the contractual arrangement with providers and the big shift in neighbourhood health. And so there'll be a number of plans, if you like, that will then deliver that, the overall 10-year plan. Not all of those have been set out at present. I guess this work of resetting the commissioning bit is part of that jigsaw, as it were. And I kind of, to take the point, it's almost perceived as a distraction, but it's actually quite necessary enabler to make sure we've got the right people doing the right responsibilities across the system. So I can't really answer your question in terms of will this enable us to deliver. It's certainly put us in a better place to deliver the 10-year plan, but we've got elements of that delivery still to set out. Is the disposition.
Very much, thank you. Now we go to Councillor Trimble.
Thank you. I'm sorry to come back. I did have a couple of questions, and what I didn't want to do is just dominate the start of the discussion. So I've got a couple of things that have just cropped up. So you spoke about how it's a cut, and it's 50% cut to the actual delivery side of things. So the management, not what we receive on the ground, but the people who are working on implementing the work. So the ICB staffing. Were there too many people working on ICB related roles? Were you finding there were a lot of people who had spare capacity? Is it going to function? I think you touched on it, Chair, yourself, when you said that, yes, that's fine, but actually we're going to find that with fewer people doing the same work, that eventually that's going to slow down delivery on the ground. I wanted to ask just very quickly, we were talking about the health and wellbeing. And you did mention the Somerset board, and it did occur to me, because I used to be the opposition lead member for public health. So I sat on the Somerset board and the health and wellbeing board. They're not the same thing. They're joined together under the Somerset board for some of their functions. What's happening with that? Is it going to become one very large board as such, or are we still going to have that individual one? And then also page 35, so we've got detail here, the scope of our cluster ICB. And it says, point 2 says, a very small number of delivery-based functions will be stopped, and our responsibilities for the performance oversight providers will change over time. Stopped and passed over to somewhere else, or stopped altogether. And then also it says, our cluster will continue to host the regional collaborative commissioning hub, and we will take on additional delegated functions from NHS England. And so what I want to know is, are you dropping some work or work up? Where is the work that we're losing going, and what are we picking up, and is it manageable?
Thank you for that. I might need Alice to come in and put the board configuration just so I'm clear on that. So certainly there was two things that were set out at the beginning. One was a kind of a blueprint that was termed of what they want the new organisation to do, and this was through NHS England. And the second bit alongside was the kind of the reduction in your operating costs to meet that blueprint. And so that then led to this conversation we've had, which was around, okay, but you couldn't make that change on your own. You had to then move into a kind of a merge of the organisations to achieve the scale you've got. So that enables you to work more efficiently, because we don't need 3 of everything in that new organisation. Sometimes you do, sometimes you don't, and that's what we're working through in terms of the structure of the new organisation itself. So kind of, I guess that the requirement to meet the reduction in operating cost took us into a conversation about how you work more efficiently as an organisation itself. So it's not those people sat around not doing anything at the minute. Yeah, no, I appreciate that was where you're coming from. But it does then take you into a place of, well, how do you use better use of AI, for instance, in order to sort of transact some of the business that you do, and can you work at scale then across a bigger footprint for some of the roles that we've got? And is it the check at the end of that, is there an impact? Come back to the point you made, is there an impact on the oversight of services, was what we do as commissioners, and that's the kind of sense check we're going through at the minute. So we've got kind of a version 1 of what that structure looks like that fits within that financial envelope that we're getting feedback from the teams on, and we're also then checking amongst ourselves and partners to say, does this still maintain our statutory responsibilities and discharge those safely? The piece about the Somerset board, my understanding is we call it Somerset board, it might be something different, but the Somerset board for us is the joint health and wellbeing board and integrated care partnership. And there are conversations about kind of what that looks like in the future, but that is what is in place at the minute. And particularly around neighbourhood health, also the role of that board changed slightly. Through this commissioning, there might be opportunities to devolve commissioning budget to a local level, and there's a complexity around that. But we're working through kind of what configuration of governance would enable us to do that. It's very early days in those conversations. But certainly that's the briefings we've had a conversation a couple of weeks ago at that Somerset board at the minute, and do correct me if I'm wrong, Alison. That's the Integrated Care Partnership and the Health and Wellbeing Board combined as a committee in common. So that's that bit. In terms of the things we're stopping, it started off as a longer list of things that we're stopping, and then it has got to a very short list, and that's the kind of the view of the centre in that. The other changes that are taking place, the regional team will be picking up performance management of providers. So they'll take more of an interest in waiting list reduction, more an interest in kind of the waiting times, etc., and the performance standards that the providers work to. So that's been set nationally, that change in role. So we currently do that, and that would be the regional team that would do that with providers, and we'd be a part of that process. We're just working through how that's going to work in practice, because clearly whether you can achieve performance standards relates to how well you've been commissioned and how much money you've been given and how much kind of resource and time. So that kind of there's a second change with the regional team picking up performance management providers. The commissioning hub is another complicated bit of it. There's some services that are commissioned regional wide, and Somerset ICB hosts that team at the minute, so it doesn't necessarily sit within our structure. We host it, and we'll continue to do that in this new organisation. So that's where the hub comes into. It's a hub for the region, and that's commissions generally kind of highly specialised low volume work, and also then kind of the more kind of transactional elements of primary care.
Okay.
Thank you. Yes, you can.
I'm so sorry. So you mentioned a real sort of, I don't know, sort of torchlight word at the moment, which is waiting lists and the management of waiting lists. So are we going to see a different approach to waiting lists? We know that nationally there's discussion about how people are even going to be sort of reduced access to being put on waiting lists. So is that part of this, or is this just a administrative function?
Just to go into that one in a bit more detail, we'd be keen to take a broader view of people waiting on waiting lists, and are they waiting on multiple waiting lists? Are they being disadvantaged because of the kind of their health and equality perspective and the area they come from? So there's kind of that in the commissioning line will be still the responsibility of the ICB. How providers are managing the performance against standards around waiting lists. It's a conversation with the regional team. That's where it all get quite complicated in terms of that relationship, which is why we'll have to work closely with the regional team on that. But the kind of whether a provider is achieving the sort of reduction waiting lists that they set out to achieve and they set nationally is a conversation they will have with the regional team moving forward. Our approach will be actually how do we kind of from a commissioning point of view increase the prevention so people don't end up on a waiting list in the first place, and then when they're on the waiting list, how do we treat that waiting list in a way it's not just about time, but it's about the impact on that individual and other trends in that we can see from a population point of view. So we would still have strong interest in that from an ITB perspective in making sure the waiting lists are reducing over time, but the actual official performance management of the provider on that will be with the region.
Okay, it's big. I'm not asking more.
Right, I'm just going to, I've got people on the list, Councillor Redmond, I haven't forgotten you, you're online, so don't think I've forgotten you. But can I go to, can I go to our, can you give me your official title, Alison Bell, please?
Yeah, thanks, Councillor Slocum. So my name's Alison Bell, I'm the Director of Public Health. So I just wanted to supplement some of what David would say. I know I'm not a member of this committee, but it might be helpful. So the information that David shared this morning is exactly what he shared with the Somerset board, and Councillor Wakefield can speak to that because she sits on the Somerset board, as does the lead member for children and families and the lead member for public health. So there is quite a lot of democratic representation on the Somerset board, and as David said, it is chaired by Bill Revens, the leader of the council. So I think what Jonathan Higman said, the new chief exec of the cluster, is really helpful in that he said try and focus on us building a new £45 million organisation than defending the demise of an a previous organisation, if you want. So try and be forward looking, and it is a completely different function. It is going to be looking at how at the cluster level they do the data analysis and look at the outcomes we want to improve. And then at place, we're suddenly going to have a much stronger role. So we've already changed the membership of our Health and Wellbeing Board, Somerset Board, to get more providers onto that board. So the GPs are now represented, and I think that will evolve over time. We already have pharmacy represented, we have the acute trust presented, but how we work together as providers, and that's care providers as well, because we'll be responsible for trying to improve outcomes within our place. And right from the beginning of this journey, when the NHS and central government made these decisions, we have been feeding back, and that's how the long list of things that were going to be stopped. We said, you can't stop it, you can't stop doing emergency planning locally. So we've been feeding back, and that's why the cluster looks like it does now. So I just wanted to speak sort of in support of David that you are being done to a bit by the NHS, aren't you, and central government? But I think we've set up a local authority cluster group. So I'm the DPH rep across all the areas, Wiltshire Chief Exec, I think it's Dorset, DAS, and I don't know which DCS it is, but we're working together to shape that thinking of the cluster so that local authority services are not disadvantaged by these changes and there's no cost shunting, but also that key functions that we're responsible for, we can still deliver effectively in partnership with the NHS, which is how we've always worked. So I don't know if that's helpful, but we have been speaking up when we don't think it'll work. And today, I think our relationships in Somerset are really strong with our NHS colleagues, and they have listened respectfully. So I hope that helps. And I'll be quiet now, Councillor Slocum.
No, I could see that you wanted to get in, and then that has really helped a lot, because we were going down a negative route a little bit perhaps, and David is doing very well, but I think that does explain. I think you have to forgive this committee that we are very concerned and care a lot about Somerset, and we're only going to care about Somerset. Of course, we care about the world, but Somerset is our main priority, and I think we don't want to see services reducing. We don't want to see any of the mechanisms in place that we see faults now. So there are really serious concerns. So thank you for that. Right, I'd like to go to Edric Hobbs, Councillor Edric Hobbs, please.
Thank you, Chair. Alice has answered one question. I was going to ask what liaison has been done with other areas, because I was going to say I appreciate you're having staff cuts in the admin area. I was going to ask where there's cuts made in each area. And would you end up getting them and us across the board, so we've lost more than they have, etc. And is there any point in maybe having a cross-area scrutiny where maybe a couple of members from each area scrutinise it together? So rather than just taking in isolation, when we scrutinise, are we just scrutinising the Somerset bit, or are we scrutinising what goes on across the whole area? Because I can appreciate the needs of a large urban area like Swindon or Bournemouth, I know Welsh, my stepdaughters are very different to maybe Carers Patch or bordering on Exmoor. So I just wonder about maybe do we have maybe an online cross area scrutiny? Is there any benefit in that, or is that taking it opposite level, where, as Alice says, you discuss things with people from the various boards?
I mean, we couldn't discuss this further, but we could sort. I mean, in a minute we'll end up going to America and sorting that out. I think we need to be very careful and very focused on what we need to do here. But thank you for that suggestion. I think we'll keep that on the table. Councillor Whale.
Yes, I'm honoured. Must be important. I've got a name tag. Yeah, this, of course, is not a reorganisation locally. This has been brought about by a government dictate, if you like. I think you've got to look at it at that level before you start looking at it locally. And you know, if I'm right, I'm thinking we've been told that it's going to affect the administration of the organisation, which means there's going to be job cuts on at that level, and that's right. I understand that. What I haven't heard is, are you going to be able to do your own procurement? Because all we hear a lot about the NHS and procuring and how much they have to pay for their drugs more than outside drug and such. Will that be part of the cost cutting as well? Will you be able to do that, or will you still be tied to the NHS in the form of procurement?
So there's different levels to procurement. There's the NHS supply chain, and there's an ability to then buy at scale through that. When we done it from an ICB point of view, and many providers would use that to try and generate the efficiencies of volume in buying supplies for a hospital, for instance. We as an ICB and as a cluster ICB, we would do procurements for services, and we would still be doing that moving forward. So we would still run our own procurement exercises, and go out to the market in a way that is when it's needed to do so. But yeah, so to kind of that aspect of it shouldn't be impacted by this.
So, will that mean that part of the cost savings will be done in procurement or not?
So not, no, it's done through the operating costs. It's mainly the employment of staff and colleagues, and the operating cost of buildings that you occupy. That's the sum total of the pot that we're talking about, not sort of the services you procure, just to be very sure of that. Thank you.
Thank you.
Thank you very much. Thank you. Now we go back to Councillor Cameron.
Thank you very much, Chair. And I just wonder whether this comment might help colleagues. So it is absolutely true that this reconfiguration is not going to impact initially on the delivery of services. So what we're seeing within our own areas will remain the same. The planning number that of Health was to reduce running costs across the piece to an £18.76 number, and I see that David's nodding his head to that. The reason being is that the actual running costs for each ICB varied across the country, and the average was £32 odd, £32.98. And so Somerset ICB may have been, let's say, at £33. All that they've tried to do here as part of that 50% reduction within the ICBs is actually try to have the same sorts of size organisations delivering a number of functions. And as part of that reorganisation, they've suddenly realised that they can't do all of the same functions they used to do when it used to cost around about £30 odd or whatever it may be. Therefore, some of those functions that have been done in ICB world are moving to other providers, notably in the acute sector, etc. But then they're reconfiguring. We used to term the CCGs, remember CCGs and strategic commissioning groups, etc. All of those functions are coming back into the ICB because it was recognised that through commissioning you can do all of these changes to the way that we deliver health care, and therefore move into those three shifts. And I'm sorry, David, I've got any of that wrong, and I'm sorry to the rest of the committee, but maybe that helps.
I think at the moment, I think everything helps. I think that, thank you very much, Councillor Kier. I think what I wanted to say to you, David, what I would like to see when you come back again is something that Councillor Trimminall mentioned. I would like to see you being able to quantify the savings. So for us, you're having to save 50%. So I would like to know when you come back, what it cost you with the ICB as it was, and what the initial savings are going to be to the ICB deliverers, or not the deliverers, the top guys at the top, ladies, and then let us know these are worthwhile, they're efficiency savings, but the delivery of the service will not be impacted. And I think we need some comparisons. We need to be able to know, we need to know the reasoning, we need to know the wherefore, and is this going to work or not? Do we feel that this is going to work by cutting off the top shelf a little bit, by making it more efficient, by joining in with other areas? Our major concern is that we believe Somerset is very, very different than, say, Swindon. Very different. We've got far more mature people, elderly people in this part county that need different needs. And that's really imperative that Somerset is treated. We talk about equality, we want equality for all of this, but we also want the knowledge that you are actually realising the difference between Somerset needs and the needs of Baines and the needs of other areas. And that's really important, because at the moment you've sort of come in like you're selling a car to me, and I'm not sure if the engine's going to be any better than the one I got. Do you know what I mean? And I need you to be able to quantify it. If that's a simple term, I didn't mean that disrespectful. But what I mean is, it's just for us to be able to understand that this is a good reason. You haven't got those facts yet. I get that. You haven't got it. But when you come back to us and actually be able to explain to us, this is what we've been able to do. We've saved this because of this. That will make much more sense to us than actually coming here and say, because all we're fearful is, at the end, we're all of us fearful, at the end, the delivery will not be made. So if you could do that for me, I would appreciate it.
I think there's something about then broadening out a little bit as well with the provider changes.
Yes.
And because I think that'll be more reassuring about what we're doing at neighbourhood level and what providers will sort of do moving forward also. So a bit more of a broader scope will be more reassuring.
That would be really good. Do I have any more speakers before I go to the people online? Because they've been very patient. I'm going to go to, is that okay? Anybody? Fine. I'm going to go to Councillor Redmond, please, who's waited very, very patiently. And Councillor Redmond is the chair of the Children's Scrutiny, so I know this is very pertinent to him. So, Councillor Redmond.
Thank you, David. Thank you. Just first point, will the slides be shared? Because they would be really interesting to.
Can you? You're very quiet. Sorry.
Oh, I'm sorry. Let me bear with me. Let's see if I can change that. So is that any better?
Online, you're finally. Online, you're perfectly clear.
And you won't know this, you won't hear this very often probably, but Lee, you're.
So I think it might be your end, the speaker may be playing up, because the online is but I'll raise my voice just in case. It's interesting that you're here today, David, so thank you. It's good to know that finally some shape is taking place with the new ICB, even if it is currently at an upper tier level. A number of my points have been asked, but I think it's important to make to ask my three questions. One on finance, one on safeguarding, and a further one on oversight. It's good to hear your comment about operational cost reductions rather than frontline cuts. But if I'm right, an integrated care board is a statutory NHS organisation responsible for planning, funding and overseeing most NHS services within a defined area. But now that the ICB covers more than one area, when we had Somerset ICB, money from government that went into that ICB was spent in that area. With the expanded footprint of the new ICB, the point I think is important here is what mechanisms would ensure Somerset residents receive a fair and transparent share of resources that reflects its population needs, rurality, and the existing service pressures. My question in relation to safeguarding during the restructure, but given the scale of the restructuring that has been driven nationally, how confident are you that safeguarding remains a top priority? And what assurances can you give that local safeguarding risks in Somerset won't be diluted within the larger system? My final question is a bit on oversight again. Just for clarity, Councillor Bruce made a great point that I think you did not fully answer. Touch points are not opportunities for challenge. And then the Director of Public Health talked about strengthening the Somerset board, but their influence is still limited. what external oversight is in place, and what role will local people like us have in influencing or challenging funding or structural decisions within the wider ICB? You're here today to inform us, but where is the ability for us to challenge, please? Thanks, Chair.
Councillor Redmond, thank you. What to you, David?
Yeah, thank you for that, Councillor Redmond. I think we picked up in terms of the funding piece, the sort of allocation for Somerset would remain unchanged this year. Building our needs, we should be in a better place to understand how the resources delivering value in each of the areas moving forward. There was a question at the Health and Wellbeing Board around a concern that potential deficits in other areas that are kind of impacting Somerset, and I'm pleased to say that the Dorset system has delivered a break-even position this year, and although there's some financial challenge in BSW, they're on their way to try and resolve that. So hopefully that is a more positive picture. In terms of safeguarding, there again, we've touched on that through the conversations with council colleagues. We've set out a proposed structure for safeguarding and a way of working on safeguarding, and there's a conversation within Somerset about whether or not that it fully meets and discharges, and the council and the health are both assured that discharges responsibilities with regards to safeguarding. So that conversation is live at the minute, and it remains, just to answer your question directly, it does remain a top priority. The statutory functions that the ICB holds and will continue to hold remain our number one priority. There's a point around the challenge in terms of current external oversight, and is through the NHS, through the regional team at present. Very happy, as we touched on, to bring further updates through here, accepting the view of the committee that kind of there's a concern about the loss of Somerset's kind of I guess leverage and so within that organisation, and I totally see that. Those were the kind of 3 points I was going to make.
Check.
Thank
Can
you very
I possibly
much.
come back very quickly, please?
Yes, Councillor Redmond, yeah.
David, thank you for your response, but I'm sorry that just the fact that you're comfortable that the funding for Somerset will be the same this year doesn't fill me with confidence, because that just means that next year it won't. And so there'll be how do we challenge that? And the fact that you're talking about, it seems every response you have is internal challenge. That doesn't necessarily generate proper oversight, proper scrutiny. How can people like us influence what's going on? Because the fact that you say funding this year is okay, that's not going to guarantee that Somerset's going to get its share next year. And I'm not assured in any way that we can challenge it. We're listening to what you're saying, but how can we influence what's going on, please?
Yeah, just to give you a bit of reassurance, certainly all the scrutiny committee appearances that we've got across the cluster, as a part all the feedback from the official consultation internally at the minute with colleagues is one bit of feedback. We're obviously getting feedback from partner organisations through the ICB boards. We've got a cluster board coming together with council representation on that, and that's being set up at the moment. So we're all feeding this back in terms of the concerns that people are raising in forums like this. It's been fed back into the executive within the ICB, and that is influencing then the direction that this takes moving forward. I'm picking up through the last couple of conversations, there's a concern about the financial arrangements and a concern about having adequate resource moving forward. So we'll get more clarity to you around what happens after this year that we're in due course. I'm happy to take that away, Councillor Redmond. But yeah, just to be reassured, it's not today's conversation doesn't not go anywhere. It goes back into the decision making over this. I'm very happy to say come back and keep the conversation going to other meetings.
Thank you,
Thank
Chair.
you very
Just
much,
a quick
Councillor
point,
Redmond.
Chair. But just for clarity, David,
honestly, 20 seconds.
just for clarity, the
Carry on.
councils like us have a statute requirement for oversight, the ability for scrutiny committees to challenge the executive and council is there. within the NHS, that's not present, and it needs to be something that's considered.
Thank you, councillor Redmond. I do think we're very fortunate to have our member here as well. Our local member here who's actually sits on those boards as well. So I think any challenging, Sarah will obviously bring about anything she wants to say. Oh, sorry, thank you. Sorry, apologies. I need to go to councillor Oakes, if I may, councillor, because I've waited for councillor Oakes, who is also the lead member of Public Health.
Thank you, Chair. Apologies for not being there. I experienced the NHS at the weekend, and I don't think it's appropriate to share the details of abysmal performance at this time, but I will at some point. I must say YDH were brilliant, but the wider NHS failed miserably.
Lost you.
Can you hear me now?
No, councillor Oakes, we lost you. Could you just say the second sentence again, please?
I ended it with saying how wonderful YDH were in the end. Thank goodness. The reason I keep my comments brief because I'm in quite a bit of pain. So what I just wanted to check was, I thought right at the start David said that the senior team now are becoming civil servants. Was that correct?
The team within NHS England are becoming civil servants. NHS England's moving into the Department of Health and Social Care.
Right. Okay.
That doesn't affect the ICB team. Councillor Oakes.
Right. Okay. The point that Councillor Redmond's made is incredibly valid. There is a role for the council and it's unique in that we are the only ones who can really hold the NHS to account within Somerset, and we will have to do that. My concerns about this reorganisation, I knew it was going to happen. Labour governments always reorganise the NHS. That's their thing. I knew they would reorganise it and make it bigger. My concern is that this doesn't just affect people who are administrators. It affects key specialists as well, who I'm worried about we will lose in this process. So what I'm hoping is that we will get some input, at least some feedback, an opportunity to speak to you again about the detail as this proceeds forward. If we lose colleagues who work within the NHS, it is a complex system. There are public health nurses, for example, who work within the NHS and do a wonderful job. And I want to ensure that they are protected because the work they do is invaluable. At the moment, it's not clear. I mean, we know what the top are doing, but the real people who matter, the ones who do the job day to day, we're not clear on their position, and I'm sure you probably can't tell us yet. But I would welcome you being able to come back to this committee to explain why certain changes have to be made, because it's the operational side of the NHS that affects us.
Yeah,
it's the operational side of the NHS that is not functioning. So.
Thank you, councillor Oakes. I'm sorry to hear that you've had this unfortunate accident. I also had one yesterday, so I have my sympathies with you. And we didn't have it together, I might say, but we did have one. So thank you very much for being online. Thank you. I think that okay. How many people want to come back and speak a minute before I just councillor Trimnell, okay? Because we just need to move forward.
I totally understand that, Chair. What I wanted to suggest is that I think that there has been a feeling on this committee of a concern about that fair share, about how Somerset could end up being overlooked for the larger acute operational services and things. And so I wonder whether this committee, if we're looking for recommendations, might consider, I know it's just writing, but I feel as though we need to make that point. I think that was the greatest concerning point. We know that this is a government initiative. This is something the government's decided to do. It's not your fault. You've been told to do it. You're just doing what you have to do in a way that you can best continue to operate. But our concern is for our area, you know, when you're competing against those big hospitals, are our hospitals going to be overlooked? And so I think that we need to perhaps put something into writing as a committee to say that we would like our voice to be considered in this, to be heard in this, and that Somerset residents are protected from losing out in this
Yeah,
system.
I think great. I think our lead member, would it be okay to, councillor Wakefield, to put this to the to the executive? That's the right way, is it the right way to do it from the executive, to say that we've had this today, we've obviously raised really concerns. Again, David, you've been marvellous about answering the questions. Sorry, you've had a bit of a full on, but I have to say, I think that we are not happy. We are definitely not happy. That message needs to go back, that we're not happy. We just want to see the concluding evidence that needs to come back. We want you to come back sooner than later. But I just wonder whether we can put the recommendation, councillor Wakefield, your idea would help me.
Yeah, I'm very happy to do that. Of course, as we've said before, Bill Revens is the chair of the Somerset board. And certainly Duncan Sharkey is on the ICB, isn't he?
Yeah.
So we do have representation, and I can assure you that Duncan's role, just as Bill's, is to make sure that Somerset's voice is heard and isn't lost. I just want to comment generally on this, and I appreciate people's concerns, and I'm not trying to say everything's going right, but I've lost count of the number of years in which I and many people I know have thought that the NHS needed reorganising. And part of it was the bureaucracy at the top of the NHS that needed sorting out, too many chiefs, not enough Indians, all that sort of stuff. So I'm really pleased that this is happening. Yes, we need to keep a really strong watching brief over how it affects us, how it affects Somerset, and I can assure you that that's part of the job that we are all here to do, as Alison has already mentioned. So yes, you can put forward your concerns, and I will certainly share them with the executive. But I think this is an opportunity. Anything else. It's an opportunity to make the health service represent what the 21st century needs, not what it needed in the 1950s. A 10-year plan is what's always been needed, because you can't do it overnight. And as we know from running the unitary authority, trying to mend the engine when the aeroplane is still flying is extremely difficult to do. Doesn't mean it can't be done, but it's very difficult. Services. So we're worried about that. We're worried about services not being kept going. We're worried about an organisation that's more remote, because that's what it's going to be. And I think that's something that we all share. But there will be representation from across the different counties. We all have our own ways of working. But in Somerset, we have this wonderful opportunity, which we've had, of being the same geographical footprint. And that will carry forward. We've got some things to offer everybody else who's coming into this cluster, actually, because we're doing it already in the right way. So I think, as I say, see it as an opportunity. But yes, of course, I will take your concerns forward, and I absolutely will look about what happens to Somerset and where it fits in. I hope that's helpful.
Councillor Trimmer, thank you. Councillor Trimmer, do you want, you've heard from the lead member, do you still would like a recommendation? If you would, then obviously we will put a recommendation. It was just nice to know we could. But obviously councillor Wakefield is well aware of everything here. So you should. But you're happy, would you like to?
Yeah, I really would. And I don't think you're saying not to. And I don't disagree either with what you're saying.
No.
There does need to be reorganisation, but 50% just is a sort of, it sounds a bit of an arbitrary figure. We just want to know that it's being done in a way that isn't going to cause negative effects for the people in Somerset and more positive effects for people in other areas, for example.
Well, that was very good. Did you capture that? Did you capture that? So that would be the recommendation, I think. I think that would be very, very good.
Could we have a point of order?
Hang on, just 1 minute. Sorry, councillor, I'll come back to you. Councillor.
Well, it's just with the recommendation, it's just adding a time frame for when they can come back, so we can scrutinise it further, because that'll be 6 months. Would it be 6 months? Possibly the next time?
3 months.
3 months. I was saying 3 months. Yeah.
Yeah, 3 months.
So that's the only thing I wanted to add.
Yeah, we're going to work the proper recommendation out in a minute. We'll work it out properly because it needs to be. Thank you for that. Councillor Cameron.
Are we going to be voting on this?
Yes.
Okay. Thank you.
Of course. Councillor Bruce.
Thank you. I have to agree with a lot of what Sarah said. I'm in principle in favour of this reorganisation. I think it's a good thing, and I was very much encouraged by what Alison had to offer earlier as well. And as Place Director for Somerset, David, hopefully we can give you some support in defending the Somerset corner, because you are Place Director for Somerset. So I think my point really is in terms of scrutiny and that were you talking about going to the Somerset board? I had a look just quickly at how it was worded and it was an update to the board and you said it was the same update that was brought here. So I think it's really important as scrutiny for us to be involved in things before. So coming to scrutiny or going to the board with an update, you're basically saying this is how it is. And so I'm a bit confused. Alison said that there's been input, there's things have been changed, but have they been changed after they've been done? So it was just really to urge you that when you do come to the board or to the scrutiny, that you come before the decision's made, that we get that chance to feed in because we're not an official consultee. But if we're going to be able to input to make some influence or impact, we need to know before things are changed. That's all.
And I think the one thing I wanted to say, David, I brought this up at a pre-meeting, a couple of pre-meetings ago when I heard about the ICB. So you have very kindly come in very quickly to give us this briefing, but it's something that I do feel on this committee, we feel like we've got to keep our eyes open all the time to any changes, and we've got to ask for it to come back. Whereas really what I want is I want a direct link with you from now on. Okay, that I know what's going on because you come back very quick with this and we really appreciate it. But so I think, are you all in favour? Mr. Bright, could you read the recommendation and then we'll vote on it?
Could I ask Councillor Trimble to repeat the wording?
If I remember what you've got and then she'll tell you.
Oh, I've just been reviewing the transcript. I've just been reviewing the transcript and trying to work out the exact wording. But obviously it is to write to the executive lead member. I'm trying to establish the exact detail of what we'd like within that.
Yes, I think that's right.
It is to express that I think this scrutiny committee would like to have the opportunity to put across the need to Somerset residents and ensure that Somerset doesn't get lost. The needs of Somerset doesn't get lost in
more remote.
Yeah.
Can you read out what you did pick up first? Because I think
you never go to the same sentence, do you?
You were talking about fair share.
Fair share.
I wrote that down and losing out on funding.
Yes, I
Especially specialisms as well. You don't want all the specialism to disappear.
No.
I think he's got your wording, so I think.
If you're happy, Chair, I'll review the transcript and we'll pull something together after.
Yeah, that's fine.
That's good. It's recorded. Thank you. So that's what I was trying to say. We've got your word.
Yeah.
But first of all, I need to vote on. Is everyone, as members, would you like to vote if you're happy for a recommendation, please?
Should I propose and second?
Oh, yeah, proposer.
I'll propose it, yeah.
Councillor Trimble, Councillor Parrott.
Sure, you've got your mic on, sorry.
Oh, no, I do apologise. Sorry. I always think you can hear me enough. Okay.
That's the problem.
No, sorry. We've got a proposer, we've got a seconder. Can I have all in favour of a recommendation, please? Right. 7. All those against? All those abstaining? 2 abstentions. Okay, so we'll put that recommendation together. But I want to thank you all very much for this input today. David, especially thank you.
Thank you.
It's because we care, not because nothing against you. You've been very, very good, and Alison as well, to clarify those points. I thank you very, very much. But I do want to see you. We want to request, please, that you come back within 3 months to our community. Maybe even sooner. But we really do need you to come back with those questions that I gave you earlier, if that would be possible, please. Okay, and perhaps we can liaise together with the vice chair and you and myself.
Yeah.
To actually think on the proper dates. That'd be okay?
Yeah, certainly, yes. Thank you for the comment.
Thank you very much. Thank you. I'm now going to give the committee a 10-minute break, please. 10-minute break. So you'll be back here at 5 to 11, please. You've actually got a little bit more than 10 minutes, but 5 to 11. And health workshop. I'm going to invite Councillor Wakefield to introduce it, and then Emily Fulbrook to present the item. Over to you, Sarah.
Yes, thank you, Chair. Right, well, briefly, this is 2 separate things, really, although they interlink. So we've got the draft adult social care strategy and the draft adults and housing work. Separately, there are two separate documents. One is a supplement, so it's not in the original paper, it's in a supplementary paper. Our council and our staff that we refresh our policies regularly and that we co-produce them with our supported persons, communities, carers and staff. So I think you'll find that as the documents are interesting, we've had an engagement about strategy for the adults, which closed on 27th of March, which is being evaluated, and further work needs to be done to bring the results of that to the committee and the strategy as well. These are about how we will work going forwards. I think if we look at it that way, there's an emphasis on prevention, having a skilled workforce, of course, giving the right support in the right place at the right time, and making sure that we have a sustainable service in Somerset. With the workforce, it is of course important to keep in touch with them, to listen and learn from them and implement the valuable feedback we get. We need to have a staff that have clear priorities about what they want and about which they can coalesce. And this is important for attracting, retaining and a good quality and sustainable workforce, which is what we need. I also think you might find some of the statistics on age and diversity profiles, which are shown in the equality impact assessments, quite interesting and useful too, if you haven't looked at them already. It's just quite interesting to see how Somerset breaks down. But that's all I'm going to say, and I'm going to hand over to Emily.
Lovely, thank you, Sarah, and thank you, members. So Vicky Chipchase has been leading both the adult social care strategy and the adult social care and housing workforce strategy. Unfortunately, today she wasn't able to be here due to end of term, so I'm presenting on her behalf. I'll take you through the adult social care strategy first, and then we'll move on to the adult social care and housing workforce strategy. So if I go through the, I don't intend to go through every single slide, but just to give you a brief overview in terms of how the revised framework will work. So this is the adult social care strategy. There is going to be a separate housing strategy that is going to be in development, but this is solely focused on adult social care. The adult social care strategy is informed by our market position statements, our commissioning strategy, and then further underpinned by our service plans, our quality and performance and assurance service plans, and our operational plans as well. And again, that's all underpinned by an adult social care performance framework as well. So as part of the adult social care strategy, we have undertaken a number of engagement opportunities. So this has been completed with our workforce. We've had some feedback on the draft vision and feedback on the draft objectives and identifying any gaps. What we've also done is had an online survey for public and professional stakeholders and partners as well. The online survey closed on the 27th of March, so we haven't had an opportunity to fully sort of review in terms of all the feedback that we've had from that online survey. So we're working through that at the moment, both the online survey and also the other targeted engagement that we'd undertaken to really co-produce the adult social care strategy. So we've had some targeted engagement through the following, so through Health Watch, through our voluntary community, faith and social enterprise networks, through patient participation groups and citizen space, our mental health lived experience coordinators. We've had a variety of posters that have been put up across in libraries, GP surgeries, through our Somerset Independent Living Centres, and we've also shared that through the Somerset Council's Facebook page to get as much public engagement as we possibly can do. We've also done some further targeted engagement through we've attended some unpaid carers support groups. We've done some face-to-face sessions with people with our learning disabilities communities through a service called My Days and Open Storytellers. We've attended talking cafes, including our homelessness and rough sleeper community cafe as well. We've attended the Armed Forces and Veteran Group. We've attended Afghan families supported to complete questionnaires at some of our welcome hubs. And we've engaged with people with vision and hearing loss. And we have a BSL version of the survey promoted through Deaf Plus and Somerset site. We've attended Headway Somerset session with people with acquired brain injury, and we've worked with the Unstoppables, which is our younger adults within Somerset. We've attended the Gypsy and Traveller. We've supported our Gypsy and Traveller community to complete the online questions. And we've also completed an online session with our dementia network. We've engaged with the local community network meetings, and we've with our Connect Somerset champions as well. So as you can see, there's been quite a wide variety, not just internally with our workforce, but also externally as well. So as I said, all the feedback is being reviewed around in the beginning of April. And what we will also produce is an engagement report to share back, because it's really important that we go back out to people that have engaged with us. You know, we asked, you said, and we did. So it's really, really important. What this also does is for adult social care and housing, provide a bit of a blueprint in terms of how we want to co-produce with our communities and residents in the future as well. We will be providing a report, and recommendations will be considered within the assurance board that we have, the Adult Social Care and Housing Assurance Board, as part of our governance. And will also feed into our continuous improvement plan, again, which will be overseen by Assurance Board, which will also be presented to Scrutiny Committee as well. So our strategy themes will, we will have 5 strategic commitments. They'll have some outcomes, and then there'll be some measures there, so we'll be able to produce quite clear KPIs as well. So in terms of the draft strategy commitments at the moment that's coming through from the adult social care strategy is very much in terms of the first one being prevention and early help. And for those of you that have seen the previous adult social care strategy, the 4 key themes are remaining the same. So prevention and early help will be the first one. Here you'll see these are some of the draft sort of strategic commitments and some of the key outcomes that have been identified as well. I don't intend to go through every one of them, but I'm quite happy to be asked questions surrounding some of these. The next commitment is surrounding right place, right support at the right time. And again, you'll see the strategic commitments there and some of the outcomes or expected outcomes and how we'll be able to measure. A supported, skilled and flexible workforce, and the next strategy very much feeds into this commitment as well. And again, we've got our strategic commitments and our outcomes there as well. And then importantly, for our service to be future focused. And again, having strategic commitment there and also our outcomes. So our strategy measures will have very clear KPI data, which will be fed through by our service plans and quarterly reports. Our feedback and complaints and compliments that we receive across the service, and again underpinned as well by our commissioning strategy and action plan. We have a emerging new adult social care performance framework, which will enable us to identify and report back not only to this committee, but our assurance board and to executive as well, in terms of where we are on track where some of those KPIs may well be delayed, where there's a risk of failure, or where actually we're not achieving that commitment. There is a golden thread throughout this. So the strategy, which is then in terms of will both be fed and feeding into our strategic service plans, our detailed work plans for each service area, which goes down into individual plans. So that will be for our service managers, for our social workers, occupational therapists, our commissioning officers as well, and then feeding into supervision. So you'll see that whole golden thread that will be running through our strategy. So our next steps are to conclude the engagement programme, review the objectives with feedback received, also review the outcome of our CQC assessment to inform our strategy, and then finalise the adult social care strategy to then launch. So these are what's included in this slide deck, and what you have in front of you as well these are draft objectives, so they are subject to change following the engagement programme, and again very much welcome Scrutiny's input to help shape and strengthen the adult social care strategy. I'll stop there before I move on to the next one, and just if there's any questions, Chair.
Thank you very much, Emily. Thank you for that. Members, do you have any questions, please, at this point? Councillor Trimble.
Thank you, Chair. I always have questions. So I have a couple of things, and this is my own poor interpretation, I am sure. Okay. But when I read it through, I thought, okay, yeah, that's fine. And then when I read the equality impact assessment, and I saw that the quality impact assessment seems to suggest that people with protected categories of age and disability were negatively impacted by it. I was confused as to what I was reading, and I thought, am I not reading this properly? And I never had a chance to go back to it to look at it properly. So I'm going to ask here instead, and it might make me look really stupid because I might be reading it properly, but that's what I wanted to check. And also, page 74, there's this slide, you referred to it just now, the strategy themes. But obviously it's incomplete because there are some things missing. I didn't connect the 4 following items beneath it, prevention and early help, right support, right place, right time, etc., with that slide. It just seemed to hang there on its own. So I presume because it's a work in progress, that you would add that detail to it, because at the moment it's just 4 pictures and then terms underneath are all the same. So they were my questions. Thank you.
Thank you. The equality impact assessment is not in relation to the adult social care strategy.
Right.
It's in relation to the workforce strategy. So that's probably where your question comes from. So it's not in relation to the adult social care strategy. Is that clear, Lucy?
So I did suspect that, but I felt as if suddenly I have read things and I thought, gosh, what have I read then? What was that? So yes, I did wonder that, but further to that, if the workforce strategy is going to negatively impact people with disability and people whose age is a protected characteristic, I know there's a list of things we can do about that, or a list of things that we will work on. When will that be amended before the strategy is in place?
So what the equality impact assessment identifies is the challenges that we have, and we have got an older population. Our workforce is an older population as well. So we are doing, which is exactly the reason why we need to have a workforce strategy to think about that succession planning. How are we supporting and encouraging a younger group of employees into the service as well? The impacts and the mitigations of the equality impact assessment will be ongoing reviewed by the workshop, the workforce board, which takes place every single month. So we review that. We do midpoint reviews. We've had swap audits completed and the impact and what we're trying to achieve will be monitored as well through the workforce board, which then goes up to our assurance board as well. we've got a load of mitigations that are in place, and how we're going to address it, but we've got all the data, all the information there. We've been really successful with our previous workforce strategy, particularly surrounding our one particular area of our service, which is in my area, in the operational service. The age of that particular service group was quite high. So we looked really creatively in terms of, okay, well, what can we do here? And we created various different roles. Now, what we've got is some brilliant succession planning that we've been able to identify. We've got apprenticeship roles. So there's different ways in which we can support the workforce as well.
Okay. And in terms of that slide, will that be updated?
Yeah, apologies, Lucy. Yes, that slide will be updated. I'm just looking back now, and yes, you've only got the full pictures. What you haven't got is that prevention and early help.
Yeah.
That right care, right place, right time, a future skilled workforce and a future focus. So they will be on there.
Yes.
Thank you. Thank you very much, Emily. You did say this was in draft.
Yeah.
You did mention this was in draft, and you did say there was going to be some changes that we could make. So if that can be obviously identified today, that would be great. That would be great to get that one identified. I wanted to just ask you about the engagement. There's such a lot of engagement. I had no idea at all. You know, I guess that kind of happens seamlessly, doesn't it? But was there a common theme with most of the engagement? Was there a common theme of people asking the same question or bringing the same element of concern out?
So we are just putting through all of that data at the moment. We've got some emerging things that are taking place. Let me just get up my notes of what we've got here. No, it's fine. It's important. It's good. We will produce a report that sort of really does pull out and highlight what some of the feedback has, because as you can, you know, as I've gone through, there's been a number of different groups, each with different focuses as well. So it's been fantastic that we've had, you know, all that engagement from, and it's been brilliant, particularly in the targeted areas as well. I mean, some people have said things like, sometimes it can be quite confusing in terms of early help and prevention. Where do people go? What's our website looking like? Where do people get that information and advice from, that early intervention? And I know that's something that Councillor Wakefield is really keen to really promote as well.
And especially for the people who aren't online. I think that's the one thing we must make. The engagement is very good, but there are still a very high percentage out there who do not go online. And I worry that they're lost. I worry, you know.
Yeah, absolutely. So there is barriers. Some of those barriers have been put up as well. Some people have talked about in terms of reliance on locums as well. So locum workforce, the changes that have happened in terms of restructuring as well, consistent teams. And then there a strong support for learning, innovation, some of the transformation work that we've done. So you'll remember in terms of My Life, My Future as well, all the transformation work that we've done, and now the new transformation that we are looking to embark upon as well within adult social care. So they're just some of the sort of the key sort of highlights that are coming out. We are reviewing all of that data, so from the face-to-face engagement, the online engagement, and then we're looking at the online summary of the survey that has been completed, which we've had a really great engagement on as well, which has been really helpful with our communications colleagues have been really highlighting that through social media as well.
I'm a great believer in My Life, My Future. I always felt that was a good piece of work. It just resonated with everyone, I think. And yeah, I don't want that work to be lost. I hope it will be taken in with this. Yeah. Does anybody, Councillor Bruce?
Thank you. It's really lovely to see this coming through so early. I would just like to know, have you had much engagement from perhaps those who've lived experience of drug and alcohol addiction problems?
Yes, so we've linked in with our open mental health service. And we've linked in with the drug and alcohol service as well. So yes, there's been a variety. If I'm honest, we would want to speak out to everywhere. And this, with a limited resource, we've only been able to go to where even with that limited resource, we've been able to engage with quite a number of organisations and services. So this definitely sets the blueprint of how we want to do things moving forward. So I think this is a great start, really good opportunity of how we're going to be doing things. You'll see this much more commonly now within adult social care and housing. But yes, we have engaged with a variety of individuals.
Thank you. It's great to see also the KPIs and the measurable outcomes that we'll be able to see in the dashboard. That's brilliant. Thank you.
Yes, you feel like you're getting the answers, and I think that's so important. I think the rough sleepers and you know, the rough sleeping and the homeless played a very essential and a very big role this year in our council, and we want to. I'd like to see some statistics and how that's improving. And what are we doing? I think some of that, the lived experiences, I like that. I like the lived experience. I like someone to be able to explain what they've gone through. And I think that always makes the strategy, it makes the strategy alive. And I like that. So thank you. Does anybody else have any questions, please? Oh, sorry, I've got you written down, Councillor Cameron. I couldn't forget you.
Thank you, Chair. And I concur with my other colleagues who said absolutely impressive engagement. So pass on thanks to the team, if that's possible. When you do the analysis, please could I ask that we also look out for vehicle and van dwellers. And I know that some people might think that that's covered under gypsy and travellers. It's not the subset of all of that. But we do have that as a growing issue across the county.
Anybody else have any questions? Anything online? Oh, I'm Terry, you're going to have to wave a flag.
It's fine.
Honestly, David, all right?
Thank you. So those people I have met, I'm David Congreve, the newly appointed Exec Director for Adults and Housing, started Wednesday last week. But to echo everyone else, the massive amount of work that gone in by the team to get to this stage, and it's huge. I haven't had the chance to go through it in great detail. Meeting with Vicky, but I think things that we probably didn't necessarily pull out in there. There's a lot of focus on here around carers, and the team already identified, but that is it's our unrecognised workforce. People are supporting families without realising that they are actually carers. So there's those things in there. Not very long. So, and then the other things to think about, I think you're right, in terms of the co-production side of things, like Emily said, this is blueprint. It's something that we really want to strengthen. Nothing should be happening in terms of adults and the housing directorate that hasn't been co-produced. So that isn't where we take something in a finished article and we say to everybody, what do you think? Because that's not co-production. That's consultation. What we're going to look at is right from the beginning. What is it we're looking to try and what is our problem? What is the issue we're trying to solve? How can you, as people with lived experience, help us? And also I caught up with Ella, our comms lead this week. As Emily said, there's so much going on in Somerset in terms of prevention. There is so much, it's quite easy to be confused by that. So we're thinking about how do we increase our comms presence, and even to the point where I've asked Councillor Wakefield to do some small videos to talk about what it's like and how to access information, but also get people with lived experience to talk about what difference having services have had an impact on that. And obviously we've just got to wait for the outcome from CQC because to echo some of those bits. But I think it's really important that if any of you as elected members have got any further views, and if you haven't had a chance, please do get in touch so we can try and capture that as quick as possible to make sure that's included before we get to a final strategy. Thank you.
Thank you very much, David. David, as we welcome David to our committee, I should have officially said that. Thank you. Patting me on the back here from here. But we welcome David. He's the new Mel, and we had Mel looked after us so well. So it's a very hard act to follow, David, and we expect 100% from you all the time. Okay, just to make you feel welcome. Good. Okay. Cedric, Councillor Cedric.
Changing. I'm interested in how we gather the experience, the lived life experience of people who are homeless. As I appreciate lots of people are very reluctant to talk about how they've ended up in this situation. And without doing that middle class, oh, I buy the homeless people a coffee. I've got a few friends who are sort of the homeless people in Wales. I'll sit and have a coffee and chat rather than just sort of walk past and chuck a couple of quid in a pot. I'm never going to ask them how they ended up in that situation unless they proffer the information to me in the first place. I mean, one chap says, he's actually off the information. I like living in my town. I don't want to live in a house. I'm quite happy doing that. And now he's got the 67. He's really happy. He gets his pension. He's never had so much money. But apart from being given that information freely by somebody who was a regular big issue setter, because he just likes chatting, I was chatting to a guy yesterday, who plays the violin in Wales, and bought, sat there, bought a coffee, sat with him for half an hour in a chat. I'm never going to pry. So why do you live in a tent in the woods? I know roughly where he lives, but I'm not going to ask him. So how do we get valuable information from people who maybe have got difficult surroundings without coming across them as just a nosy middle class sort of buys the homeless person a coffee now and again?
There are, gentlemen, Councillor Wakefield.
I think you were saying what I would say. Actually, I know that our team just go and talk to people. If they know somebody's there, they go and talk and they ask them questions. Are you happy? Are you comfortable? Have you got what you need here? Would you rather be somewhere else? I mean, they will get into that. And I think the main thing, and it happens with, obviously with safeguarding as well, you need to get the person's confidence. And so they need to be prepared to tell you, because the way we live in this country, which I think is the right way, is you can't interfere with people where there's no legal right to do that. So you have to ask them questions, and if they don't want to answer, they don't want to answer. And quite a lot of our homeless who live regularly at rough sleeping do not want to answer. But I know that our team are prepared to work with them over a period of time to gain that confidence. The other thing I would mention is the GP outreach service that we've got, which is visiting people where we know they're homeless. And they are providing GP support, and because it's the same people going, they begin to get some confidence that it's the same person, you can trust them. So actually, underneath it all, it's all about trust, who you trust and when you trust. And we all know how important that is in our daily lives, to be able to trust people. And I think for some people who've had a really difficult life with lots of setbacks and mental health problems as well, quite a lot of them, that trust is just so difficult to rebuild. But yeah, that's what it is. So regularly going to see somebody and saying, are you okay? I saw you last week. How are you feeling? That would build trust.
Okay, thanks. Let's just worry about doing the wrong thing, but with the best of intentions. Okay, thanks very much. Cheers, much appreciated.
I'm going to make it really short. I just want to say thank you very much. I just feel like we're in a safe pair of hands, really, with the team, leadership, lead member, and it just is. I can't think of a challenge. I don't challenge necessarily, but it's watch this space. I'm interested in the results, interested in the how many, the numbers, but it sounds like you're going to let us track and follow the journey. But it just feel like we're in a safe pair of hands with how you're running things in the department, in the area for Somerset Council.
It's okay. I'm going to say something as well. Okay, I think we've gone through this. I just want to endorse the approach and process undertaken to develop the draft adult social care strategy, emerging and the emerging. But we will see that in a minute, including engagement with its residents. And I think communities and partners and workforce. I think that's so important, and it does make you understand a lot more of the depth of work that you have to do. And I think that this is why it's very, very good seeing it like this. And I really thank you very, very much. And I concur that we're very pleased. I think we'd like to endorse this very, very much with the changes that we're going to make, as Councillor Trimble mentioned. I think, but I think we'd like to have it come back again. And when you have the answers, when you've got all the concluding evidence, I think that'd be really good to put this on the agenda when it's the time's right, 3 months' time, if you think. But it would be really good for us to hear exactly what you found, exactly and all the elements. I think that would be really very good, Emily. So thank you very much. Thank you.
Brilliant. Lovely, thank you. Should I go through the workforce?
No, we're going to have to change this, I'm afraid. because of, everyone's busy, we appreciate everyone's busy, but we're going to do item 9, Council House Development Strategy first, because the Council House Strategy team are extremely short-staffed and they are very overworked and underpaid and everything else. So if you'd like to come forward, please, Wendy Lewis, is it Wendy?
Yes.
Yeah, please. We're going to allow, and then we'll come back, Emily. Is that okay?
Yeah.
Thank you very much.
Yeah.
Besides to the right.
Sorry, I haven't got your surname. Sir, what's your
I'm very common, I'm a Smith,
Smith? Oh, the Smith.
but not the only one.
No, okay. So we're going on this one. This is the strategy sets out on Somerset's council direction of travel for council house building over the next 5 years. It's been developed jointly by Homes in Somerset and Somerset Council. So I'm going to ask Councillor Wakefield, do you wish to introduce this? It says you are going to, but I don't know whether you need to, but we can go straight to Wendy, I think.
Yeah, I think we should go straight to Wendy because it's really under Federica Smith Roberts.
Yes, oh, sorry.
Although it's joint, but yeah.
I think that's been the wrong typing. So over to you, Wendy. Thank you and welcome.
Sorry, I'm just sneezed. Right, yes, thank you. It is a bit of confusion in terms of there's a joint interest really in this between Councillor Wakefield and Councillor Smith Roberts. We have got some slides to go through, but just before I do that, I just wanted to, by way of introduction, so that this strategy has been put together jointly with Somerset Council and Homes in Somerset. Duncan Harvey is down as the author for Homes in Somerset. He isn't here today because he's went off a little while ago on long-term sick. And we now have an interim head of development and regeneration for Homes in Somerset in Duncan Smith, who is here today with me. I also need to explain and recognise that a supplementary report and the strategy itself was uploaded yesterday, and I apologise for the lateness of that. The reason for that was a confusion over figures in the report. 580 new homes is the current programme, and that was over a 5-year period. But in our interest of trying to be too accurate, I think, because the writing of this started last financial year and finished in this financial year, the figure was adjusted to take account of ones that had completed or were due to complete, I would say. Many of them didn't because of various other delays and various things that went on. And so then the figure became a movable feast. And this was queried by a reporter, but it was also picked up in other people. And then we suddenly realised actually that by trying to make the figures work, we'd actually done the wrong thing. And it was much clearer if we just stick with the total figure of 580 covering the 5-year period, which so I amended the figures in the document and in the supplement that was put online. So I do apologise for that sort of oversight, really, that it made sense to us that were writing it, but didn't make sense to those that were reading it, if you see what I mean. So apologies for having to put in that supplemental, and I hope that we can take the questions on that, Lisa. Yes, I'm sure you will. Yes. Right, so we've got the introduction slide on there. We can move forward a slide, please. It's got the control there, yeah. Okay, need it up there. I'm gonna have to put it on my machine because I can't read it too far up. So here we've got this. Yes, so can you read it? I'll actually read it.
I can just about read it, but yeah, they want me to.
Would you mind? I'll get up on my.
We're just trying to get it here a minute. We just can't. Somewhere that doesn't load it onto us. Okay, you carry on.
Right, this is an overview there. just as an overview, the strategy, we've brought the strategy forward because we don't have one, basically, and we've never had one. It's been something that has been missing for quite a while, but as development has progressed, it has become necessary, and certainly under unitary, we do need a direction of travel. And now with the option appraisal having, set a direction for the total number of homes to be in homes in Somerset, they clearly need a direction to go in. So the strategy sets out Somerset Council's direction of travel for the council house building over the 5-year period. And as I said earlier, being developed jointly between the two organisations. And we started this before we knew which way the option appraisal was going, and it didn't matter which way it went. Either way, it would still be applied. Yeah. And it's going to underpin our approach to delivering more, better and greener homes, building a better Somerset. So we've tried to embrace the changes proposed for the HRA in 2026 and the following 5 years, and to provide a strategic direction and structure to the development of future council housing. We look at the council's role as landlord, the strategic backdrop, housing demand, climate change, and the delivery of an ambitious programme alongside consideration of funding, risks, and key performance indicators. So there's always a balance to be struck. And there are challenges, but also innovation and new initiatives to look at and to be excited by as we go forward. So, change voices, would you like to carry on from there?
Yeah, I'm going to keep my remarks brief because I've been with the organisation 5 whole weeks and I didn't write this strategy. And I also am not aware of the geography, as you can probably tell by my accent. I'm Welsh. So I'm just going to talk generically. I have been doing affordable housing development for about 25 years, so feel free to ask me any particular question. Just the geography is probably not going to be natural to me. I'm going to start with congratulating the council for grasping the nettle of delivering additional affordable housing that not many other local authorities are doing. So well done, Somerset Council, to start. But I'm also going to balance that with drawing members' attention to paragraphs 8 to 10 in the covering report that my colleague Wendy wrote around risk. Risk in affordable housing development is of manyfold nature, but we all know at the moment the global events that are affecting our economic outlook, and that will affect the ability to deliver the whole of the programme numbers. But we will balance those things with trying to pivot in terms of development strategy to still continue to achieve those numbers, but not necessarily in the same way we might have envisaged when we approved the programme in the first instance. So I suppose my first point is I think we need to look at a broader range of tenures for this council house building programme, and that's to include maybe some options for partial sale. You'll know shared ownership, for example. I'd be really keen to introduce shared ownership into the programme. And with introducing that tenure, there's the ability then to recycle portions of capital back into the overall pot, and maybe to extend the amount of money that we can invest in affordable housing generally. But move on to specialist housing provision. By the sounds of it, we're only here for a couple of seconds, but the previous agenda item would refer making sure that the council have adequate provision for adult social care function. Absolutely a part of the strategy that we're proposing. Unfortunately, with schemes of that sort of nature, they tend to take a longer amount of time to come to fruition, and are obviously more complex in terms of making sure that the individuals who are ultimately going to live in those properties' needs are met. So my only warning on that is absolutely good to do, but will take an additional amount of time and may need additional subsidy. Purpose-built temporary accommodation or temporary housing, again, really tricky thing to achieve quickly, and to get the location and type right. It also doesn't qualify for subsidy from Homes England. So it can best be achieved sometimes by repurposing existing dwellings or existing development into new temporary accommodation. And I think the key message throughout all of the identification of the issues on the first slide. It's about partnerships. It's about working closely with the private sector, with other housing organisations, with Homes England, and definitely with the council in terms of policy formation to start generating the things that are really important to delivering the programme. And that will be around tenure. So can we move on to the next slide, please? I just wanted to mention in terms of the sustainable financial model, our desire, everybody's desire would be to deliver as much social rented housing as we possibly can, but that also takes up a lot of cash and doesn't generate the rental income to the HRA, sorry, to recycle that as quickly. So I think there is a requirement, a desire to influence the council's planning policy to ensure that social rented housing comes through the planning system via section 106. We also need to have a balance in terms of the appraisal assumptions that Homes in Somerset appraisal software will make to make sure that we are maximising the use of the available resources, but not paying too much for stock in the marketplace. And that's a delicate balance. And I'll be bringing hopefully some of the appraisal assumptions through the Homes in Somerset Development Committee for approval very shortly. We can move on to the next slide, please. Hopefully members will all know that the Future Home Standard was published by government, I think 2 weeks ago now, and we'll be looking to obviously involve that higher Future Home Standard in all future developments for the council house building programme. The problem with that, unfortunately, is it costs more. Therefore, as a consequence, we will probably see some impact on the overall financial viability. In terms of balance and mixed community, I'll also be looking to incorporate some social value agenda so that we're recycling all of the resources back into the local economy when delivering the programme. And that obviously will include an element of regeneration in the programme as well, but I think I'll be saying things that people will know. Regeneration takes time and effort and persistence to make sure that it comes through, and obviously we've got a couple of projects in the existing programme which are regeneration focused. So the final slide, if I can please. Yeah, so I think value for money is an absolute theme that needs to run really strongly through the programme, and that starts with Homes in Somerset setting the agenda of what it actually wants to deliver, so having a very, very strong strategy, and then a set of design brief and employers requirements, which means that we get great quality homes delivered at a decent price and as quickly as we possibly can. And obviously then we need to do a bit of work with our stakeholder partner Homes England to try and maximise the inward subsidy from the Social and Affordable Homes Programme 26 to 36 and to try and get the best results overall from the programme. I'll probably leave my remarks there, Chair.
So it's done as just an overview slide, really, bringing together. I just popped it over you. Sorry. Yeah, just as I think that it's already been covered about partnership objectives, so we're keen to make sure that we work together and get as much value for money and as much out of this as we can.
Okay, thank you. I wanted to ask Mr. Smith, what's your first name?
You have to be called Duncan to work in development. Duncan.
Duncan, and I expect you can sing as well.
Just about.
Yeah, that's good. I fought very hard years and years ago in Sedgemoor, under the Sedgemoor, for National Space Home Standards, because I believe the two things are linked. And tell me, I'm very worried sometimes when I see lots of housing going up for elderly that's flats. I have flats in the ward, as I'm being a bit parochial. People don't live together well. Somebody thought this was a good idea, it isn't. We don't build bungalows because we know bungalows cost more money. But in the end, it would cost adult social care less money if we built homes for life, national space standards, and we built homes that were one floor. Because even if they were just small 2-bed, I believe that in the end, lots of people who have to go into homes who are in the wrong house have to leave the house. So it's an awful circle, a really terrible circle. And I don't know why we can't get it right. So I'm really very pleased to see that you are literally taking on some of this on board. And you've only been here 7 weeks, you said? 5 weeks, well, you certainly look like you've been here a long time, and, which is good.
Feels like it.
Yeah, it does, and what I want to say is that it's your dream and your enthusiasm, both of you, is what we want as well, because people, mental health and everything else suffer very badly because they're in the wrong home. They've got a home with no garden, they've got a home with no access, they've got no fresh air, they've got all these elements, in the end cost this council lots of money. So if we can get it right from the start, I would welcome this very, very much. I just needed to say that to you, so sorry. Can I go to Councillor Cameron, please?
Thank you, Chair. I was wondering, could we put the slide up again with the green map, please? And I would ask colleagues just to look at the green map and put a imaginary, well, we couldn't get the green map, but put an imaginary line, north-south, east-west line on the S of Somerset, once we can see it.
Appendix as well.
And you can see, if you do that and put that imaginary line in there, that the east of the county, there are only 3 developments which account for 27 houses, 27 of the 580 over the 5 years. Therefore, 5% investment going to the east of the county, 95% of investment going to the west of the county. And I just would like to ask, how did we manage to derive that distribution? Because it doesn't appear to be distributed.
Right.
They don't have any, sorry, they don't have any HRA in the east of the county. They sold off their council houses. So the HRA only comes in Sagemore and the former Somerset West and Taunton, because those houses were sold away. So you have got affordable houses in the east and south of the county, but they're owned by registered providers, not by the council. But now with Homes in Somerset, we will start to build across the county. We haven't been able to do it before. We didn't have a housing revenue account for those 2 districts, Mendip and Council.
Right, lovely. Thank you very much, Sarah, for that. Thank you. Councillor Wales.
It was going to the same point as brought up. Of course, it appears that this isn't actually a strategy for Somerset. It's a strategy for the 2 housing areas and not for South Somerset. I've read it as much as I can, and there is no mention whatever of that area. And it appears to be this strategy is just for the 2 housing areas, which are going to be amalgamated. Have I got that wrong? Because I heard what Sarah just said, but I can't read anything about it in here at all, that it's going to apply to where the South Somerset sold off its housing stock many years ago, actually. So I'm confused about this being called the Somerset strategy, because it strikes me as a representative from Chard, I may mention that, but that's true. We now got Chard in, that I don't think this seems to apply to my people I represent, but am I wrong?
In a sense, you are wrong, because you haven't got any housing stock. So, but I think what we're saying is that we will be building, there will be. So I think you've got to think of this as that will do, but you're absolutely right. But it is Somerset, because we're never going to forget Glastonbury and Chard, never. Councillor Power.
Thank you, Chair. And as the opposition lead member to Federica, I have been saying this till I'm blue in the face, and she knows that. And I think every time we have a little catch up, she always goes, I know exactly what you were going to mention. I always want to make sure that housing stock are going to the eastern side of the county. And I completely understand that obviously the housing stock was sold off by SSTC Mendon and that sort of thing happening. But I want to assure members that when I'm chatting to Federica, and I'm there to obviously scrutinise, I'm there to scrutinise the opposition. But I will make sure that, you know, my generation, I've got a lot of young people that need council houses. They can't afford the housing stock, especially on our side of the county, where house prices are quite high. That this needs to, you want about your path earlier. Well, the path is to the eastern side of the county, and we want to make sure that that happens. So, thank you.
Yeah.
Any other? Councillor Trim, sorry.
Put my cup of tea down before I cover myself in it. Thank you. So I have a couple of questions. Firstly, I wanted to say thank you for the glossary was included in that, because that's something that we've asked for on many occasions, and it made it so much easier to interpret. I think that my main question would be around these key risks, and you have alluded to that already. But obviously we've got the risk register as well on page 163, and I wondered when these were set, and are they going to change given the fact that we are now in a sort of a looking towards an inflationary supply, jobs, or everything is sort of working against us. And a final question we have, and I haven't been to the first one, which Hilary is chairing, Councillor Bruce is chairing, the Housing Task and Finish Group, which, so you may have been invited to the first one, I wasn't there unfortunately, but I wondered how this tied in, because a lot, I may have this wrong, but I thought quite a lot of what we are going to be talking about, this Task and Finish, is kind of included in this, so are we a little redundant?
Councillor Bruce.
I think that it's a bit unfortunate in terms of the timing. So I've just checked the timing, and it's the beginning of May that this is due to go to executive. And Councillor Trimlin is exactly right. The Task and Finish Group is aiming to look at how we can make a difference to improving the provision of affordable housing in the county, and this very much ties in with that. So we do have a meeting coming up on the 26th of April, 27th, I can't do, before the end of April. So it's before it would go to executive. But I was going to ask actually whether, although obviously comments coming in today from the whole of the scrutiny committee is great, can we defer final comments from the scrutiny committee until after the next task and finish group meeting, so that we can look at it in more detail and add any extra comments in there before it goes to executive? Don't know if that works with the process, but the timing is a bit out of sync here for us to look at this.
We said this, that the very thing we said at the pre-meeting, that this is not working in with the task and finish, you know. Sorry, apologies. We were just saying that this was not working in with the task and finish, and we realised that, and I'm really sorry about that. I think a lot of aspects, a lot of reasoning, there was a lot of reasons why that didn't happen, but there we are. But is there any chance,
We can certainly make sure any comments today are fed back to executive. We can also, if necessary, do a supplement that goes alongside the executive paper that will look at the outcomes of that. So please be assured everything will get fed back.
I suppose the other point is that obviously we've still got a few meetings to go, and we won't actually have a final outcome from the task and finish group until all of the meetings have been concluded. So my question is really, the strategy is going through, and it's a 5-year document, but could be renewed earlier if needed. So we can still feed in after with our outcomes from the task and finish group. And if there is something that needs to fundamentally change in the strategy, can it be changed, or is that?
is this a live document? It's a live document, so there could be changes made, which is a very, very good point, I think. Certainly,
I'm completely confused. I know I've been away for 3 weeks, but I thought the task and finish group was looking at Home Finder. I don't think it was looking at the strategy for the whole of Somerset or for the whole of housing or for the HRA. It's looking at Home Finder. We cannot do a whole review with the task and finish group. We can't do that. So I'm really cross if that's what's happening, because that's not what we agreed.
It's definitely not limited just looking at Home Finder. It's looking at how we can make a difference for the provision, the better provision of affordable housing for Somerset.
I do think Home Finder was the main part we started with. It was Home Finder, and it's sort of, I think I wasn't there either. Sorry, I'm not on the task and finish. So, but maybe we can discuss this after that. That would be okay. Is that be all right? Sorry.
Can I deal with the risk point, Chair? Would you mind?
It's certainly.
I think the short answer to the question is yes. And I think we need to see how events internationally are going to affect construction cost inflation. And I don't have an answer to that question today, and I don't think you'd expect me to. I think what the strategy gives us is an ability to pivot. And by that, I mean, there are some longer term objectives with regeneration, for example, where you can't just lift and shift, you know, and we will always have a commitment to doing those schemes when the time and financial opportunity is right. And I think we have a good financial opportunity within the next 10 years because we've got a national programme which is going to support regeneration. Lots of ticks in a lot of boxes. But by the same token, what would be really good for the HRA is to get rent income into it as quickly as possible, to get, excuse my French, bums on seats, and make sure that we can get as many people in as many affordable homes as possible. And that would be a commitment, if you'll forgive me for saying so, across the whole of the county as opportunities allow. In terms of that risk then for me, construction cost inflation moves, a fixed price purchase doesn't. So Section 106 schemes which deliver social rent across the whole of the county are purchased by Homes in Somerset at a fixed price. And that's really, really, really important, because for the developer, the cost of constructing those properties may go up. For us, the purchaser, they don't. So in a short term, just a short term position, buying Section 106 properties is a really good proposition to deliver additional rental income, meet the needs of local people, and then have an ability to recycle that funds into the HRA to deliver more complex things at a later date. Forgive me, I just wanted to answer in that way.
No, thank you. That's really clarified that. I think that's much better. Thank you so much. Thank you. Is there anyone else? Claire, is there anything you wish to say? Okay, so this one is to support the recommendations being proposed to the executive, namely that executive adopt this strategy for the next 5 years, provide guidance and structure for the development programme housing revenue account, council homes, noting that the development programme will be approved annually during the HRA capital programme budget, and agree a strategy appendix 1 is reviewed after 5 years or sooner if necessary. And obviously I'd like something added to that, as this is a live document. Can we have anything from the task and finish group to be added if approved? That'd be okay. That'd be okay, Mr. Bryan. Is everybody in agreement with that?
Yeah.
You show of hands, please. Lovely. Thank you very much. Thank you. Thank you very much. And as for your first meeting, Wendy, thank you, you've done a good job on him. Mr. Smith, you were excellent. Mr. Duncan Smith, you'll probably regret having that name later on, but never mind. But thank you so much for today. The clarity on that is very, very good. Thank you.
Thank you for putting this in a bit earlier.
Oh, no, it's fine. I thank the public health, member. We're now going to go back to item 8. Councillor Trimble, I think I may have missed you at one point, but I think you got the clarity there, didn't you?
No, I didn't miss at all.
Oh, sorry, that's good. Sorry, I thought I had you down. We're now going to go to item 8, which is the Public Health Lead Member Report. This is how the council meets its statutory obligations related to public health function. It covers key topics, areas and keynote statistics, outcomes, the role of the public health team and achievements, and any changes for the forthcoming year. So I think we're waiting for Councillor Oakes. I believe Councillor Oakes is going to present this. And then inviting Alison Bell also. Are you doing this instead of Councillor?
Yes, please.
Alison, over to you.
Okay, thank you to Councillor Slocum and to the committee for this opportunity to present Councillor Oakes' lead member report for the period April to December 2025. This was due to come to scrutiny in February, but I think that meeting didn't go ahead. So that explains the time delay. I'm presenting this on behalf of Councillor Oakes, as he did have an incident over the weekend and is under the influence of strong medication. So he's gone back to bed, where I think he should remain for a while.
We wish him well. We do wish him well.
Okie doke. So, yeah, so I will be brief because I understand that you've probably all read the report, gripping report. And as Jill mentioned, this is to capture the fulfilment of our statutory duties and our activities across our areas. And the report has been written by many members of the public health team on behalf of our lead member for public health. Next slide, please. So just a quick refresher so that we're all on the same page. So what is public health? I like to start with a definition, and public health is the science and art of preventing disease, prolonging life and promoting health through the organised efforts of society. And that is really why we're in local government, not the NHS. Because where you live, where you work, where you go to school, your environment and your community determines far more of your health and wellbeing outcomes, about 50% of your health and wellbeing outcomes, than your interactions with the NHS. Because the NHS actually only determines about 20% of your health outcomes. And about 30%. So some people often post on social media. Why is the council doing public health? And it's because, well, we're obliged to statutorily, but also we will have far more influence if we influence where people live, their houses and their jobs, than if we just focus on whether they get a GP appointment or not. We do spend a lot of time working with colleagues in the NHS around healthcare, but we balance that with a lot of input into wider determinants. And there's 3 pillars of public health. So we look at improving health, protecting health, and healthcare public health. And I'm just going to take you through a couple of highlights from each of those areas. Next slide, please. Before we delve into the detail, though, I thought it would be helpful to share the services and the functions that public health are responsible for delivering. And they're under 2 lists: prescribed services. So they are services that we must do in a particular way. So that's sexual health services, NHS health checks, National Child Measurement Programme, that's the heights and weights that we do in school. Health protections, that's sort of Hinkley Point territory. Stop smoking service, the health visiting service, and providing advice back to the NHS. And then the non-prescribed services are services that we have to do, but we're given freedom to determine how we would deliver those. And those are the substance use services, dental health, obesity, physical activity, mental health, and the 5 to 19 service, which is largely school nursing. And those functions are laid out in the Health and Social Care Act of 2013. And the team we have in the council, it's about 7 to 6 people, not whole-time equivalent. We're responsible for either commissioning or providing services and functions. Next slide. So in terms of health improvement, a couple of highlights under each of our priority areas. So in terms of best start in life, we know the start that children are given, even before they're born, determines how they can function as adults, what employment they will have, and the health conditions they live with. And most of you will have heard about the best start in life and the family hubs. I know Councillor Redman has had it come through his scrutiny, and we've got this really ambitious target to increase the proportion of children who are achieving a good level of development at the end of reception year. And it's our health visiting service that is linking that with our colleagues in children's services. But there's much more going on in that space, but just to highlight. In terms of mental health work, we have seen a deterioration in mental health across all ages, and we have engaged in a lot of work with children and young people. But I'm really pleased to report to this committee that finally we are seeing our suicide rate go down. It's still higher than England average, but I think it's the work of some of the members of this committee and system partners through the Orange Button scheme, through raising awareness of suicide and not being scared of talking about it. We are actually beginning to see that rate go down, and I feel very proud of that, actually. In terms of oral health, we know we're a dental desert. I think we talked about, was it Glastonbury? Dental desert? Oh, no.
Please don't mention that again.
That's right, Charles got a new dental surgery.
Yeah, thank you.
Yes, just name checking. But we do remain concerned about actually access to dentistry. And we've been working with NHS colleagues because the pathway to getting new dental surgeries in place is not quick. But actually what we've been doing is a lot of preventative work around children and young people's dental health. So now nearly all of our schools engage in a supervised toothbrushing scheme. And we're doing work through health visitors to make sure children and parents are being given free toothbrushes and toothpaste, because if you can't afford it, that is a barrier. So there's lots of work around oral health, and our rates of decayed, missing and filled teeth are better than regional and national averages, but still 1 in 5 children at 5 have decayed, missing or wilting, which is nothing to be proud of. Food and healthy weight. I mean, this isn't all good news. We've got the second worst child obesity figures in the southwest, and we recognise that a lot of that is around availability to have healthy food and a good diet. So we've started a food audit, sustained food audit, and what we want to look at is access to affordable food and nutritious food. And the message is really on making small changes to diet and focusing on eating more of the right food rather than telling people endlessly to lose weight, because that isn't achievable and it isn't a very positive message. So making small changes to diets is really powerful. I think I came to your committee to talk about physical activity, so we won't prolong that discussion. I know I've got a lot of champions in this room through health walks and parkrun and volunteering. But yes, getting up and moving, well done, Councillor Cameron. But all joking aside, we really do need to get our population moving, because actually if they stay active, then we know that that will help them live a healthier life for longer. And one of our big successes in health improvement is around stop smoking. We have the highest quit rates in the southwest of England. We've supported in this reporting period almost 1,500 people to quit smoking, and we know that that will help save their lives. We've been doing a lot of work with trading standards, illegal tobacco sales as well, because you want to create an environment where it's easy to make the right choices. And if the price of tobacco is one of the disincentives, switching off the supply of cheap tobacco is part of our strategy. So it's multi-layered approaches. If we go into health protection, Somerset is blessed with quite a range of unique health protection challenges. Thank you. So in the reporting period, we responded to 157 health protection incidents across chemical, nuclear and biological threats. The vast majority of those were infectious disease outbreaks, flu, COVID outbreaks, scabies, brucella in dogs, all sorts of things. And our role in public health is to make sure our population's health is protected from those threats. And Graham and I have to be assured that we are doing everything we can within the council, but also a wider system to protect our population's health. Last year, we participated in exercise Pegasus, which was a pandemic exercise to test our system. And what we found is there were gaps in surge capacity across our system. And so we're working to strengthen those, particularly as we see the changes with the NHS, because they remain a category 1 responder to major incidents. And we're not yet seeing how that will be delivered in reality. It's early days. And the other thing that happened last year is the UK lost its measles-free status. You will have seen this year that we've seen really striking numbers of measles cases nationally. We haven't, touch wood, had a case of measles during this reporting period, or indeed this year in Somerset. Our measles, mumps and rubella vaccination coverage is better than national average, so 93% for MMR1, 91% for MMR2, but that still puts us below herd immunity. So if a case of measles came into Somerset, there's an opportunity for that disease to spread. Measles is one of the most infectious diseases that we deal with, and yeah, its effects can be really devastating. Devon actually had a child death a couple of years ago from measles, and that's something we don't want to happen. We don't want it to happen anyway, let's put it like that. In terms of substance use, we also put this under health protection. So we have 2,500 people in contact with our adult treatment service and almost 200 children and young people in specialist treatment. And the support is not only for those individuals, but also for family members and people in their networks that are affected by their substance use. I think we have got some really brilliant partnership work going in the drug and alcohol space. And I think Emily talked about work with housing colleagues earlier, and using people's experience that use substances to inform our housing strategy, because a real barrier to engaging in effective treatment is having a regular place to live. It's really difficult to detox someone who is dependent on substances if they don't have a home. And so it is, again, a wider determinant of health, meeting people's basic needs before we engage them in specialist treatment. And then sexual health services during the reporting period, 8,500 people attended our specialist sexual health service, and 2,500 people had long-acting reversible contraception fits in primary care, all of which we're responsible for commissioning. And we do lead a whole system approach to sexual and reproductive health through a Somerset network, because the commissioning responsibilities are really fragmented. So we kind of get everyone in a room and try and tackle the problems together. Next slide. We have a function around public health intelligence, and most of you will have seen that we published a new joint strategic needs assessment, which is available online, and a pharmaceutical needs assessment, which we undertake on behalf of the Health and Wellbeing Board. We know there are challenges around pharmacy provision, but by publishing this, we hope to try and articulate where there are gaps. The next slide, around healthcare, public health, we work very closely with the NHS to influence healthcare commissioning. I sit on the ICB board, and I try and ensure that everything that the NHS is doing locally helps us to tackle inequalities and make sure some of our most marginalised people who struggle with access, actually have access to services. And something that my predecessor, Trudy, did was about making sure that waiting lists were prioritised for certain groups, because we know that certain groups of people often find it difficult to engage. So people with learning disabilities are prioritised for access to healthcare. But back to this reporting period. So our NHS Health Checks programme is not functioning quite as we would like it to. And our performance is below where we would like it to be. This is the health check you can have to identify your cardiovascular disease risk. And it's targeted to people aged 40 to 74. And we work in partnership with GPs, pharmacies, and we have our own outreach team. If you are interested, there's a website which I can make available to you, and you can even book your own health check. I had mine a couple of weeks ago. I would recommend it. It's a bit of a nudge to think about your own behaviours and what you could do to eliminate your risks and reduce your risks. So performance not where we would like it, but we have a recovery plan in place. Next slide. We are the beneficiaries of a National Institute of Health Research grant that funds health determinants research collaboration. And the idea is we undertake research as a council across those wider determinants. And so we've been trying to build the research capabilities of teams within the council, and we've focused on economic development and getting people into employment, education, and housing as our three priority areas, and that's aligned with the council priority areas for transformation. And this partnership is not just the council, it's also the University of West of England and Spark Somerset, so it's voluntary sector as well. We are nearly there. The next one. And the next one, this is just detail about the individual programmes under HDRC. And then Graham and I felt, if we go to the next slide, please, that we don't have an opportunity to report transparently to the council about how we spend a public health grant. So we have tried to put that right, and we would welcome feedback as to how we've attempted to do it by talking about the public health grant and how we spend it. So the first thing to know, Lucy mentioned this earlier, so I knew she'd read the report, was that public health funding is largely based on historical arrangement. So ours is one of the lowest allocations in the country. It's about £41 per head of population. And there's huge variation. Some of it has been tweaked around deprivation, but actually it was determined back in 2013 about what your grant was in those days. So we are in the lowest decile of counties in the country for public health grant funding, and we're not in the lowest area of need. If you look at, I think it's Chelsea and Kensington in London, they get like 150 pounds per head of population, and they don't have the rurality or access issues we do. It's much more expensive to deliver services in Somerset. A health visitor in Camden, their whole caseload might be in a tower block. In Exmoor or at Minehead, your caseload can be scattered over 30 or 40 miles, and you might do 2 or 3 visits a day. So we really have a lot of challenges around that. It's ring fence grant provided to the council by the Department of Health and Social Care, and I'm responsible for reporting back to the Minister about how that's spent. And I'm pleased to report that this council actually has respected that ring fence, and it is only used for public health purposes. And then if you go to the next slide, this is one I'd really like feedback on. So I tried to do, it looks quite similar to the NHS one actually. That sort of, this is the pie, how is it carved up? And you've got prescribed services on the left. It's quite small, isn't it, on the screen? Prescribed services on the left and sort of a sample metric as to what that delivers. And then on the right, you've got non-prescribed services and sample products. And that's the grant for 24-25, which was £23 million, which is 1% of the NHS Somerset budget, just saying. So if we are going to achieve that left shift and get more money into prevention, that's why we need to work with NHS partners and make sure pathways don't start at the point of diagnosis. And early in life, we're setting health behaviours and getting people to think about their choices so that they live healthier lives for longer and more fulfilling lives, hopefully, and they can be part of our workforce. Absolutely. Okay. So in conclusion, I think our team has carried on delivering in the context of really massive change at the council, but also across the health and care system. We would like to acknowledge that we've had a lot of support, particularly from Councillor Oakes, but also from this committee, Councillor Slocum, the Chair of Children and Family Scrutiny, Councillor Redmond, and also I'd like to particularly thank Councillor Scully for her support around people, your advocacy work around our suicide prevention work, really. Public health is a team game, and we can't do it alone. We're like 76 people, but if you look at the next, we need to go 2 more slides. We had a visitor recently. The Chief Medical Officer, Chris Whitty, came to Somerset. He tried to come once, but we were flooded. So he met some of our lead members and some of our local GPs online. But then he did come to Glastonbury a couple of weeks ago. And so pleased. But what is really good is that he asked us to talk about the health challenges that people in small towns and rural areas experience. And so what we did is we put together a programme of housing challenges and transport problems and home problems. And we filled the day with all these challenges. And every single directorate of the council played a part on this. So we were hosted by the library service. We had the Rough Sleep Outreach team there, and the NHS homeless GP service. We had our HDRC colleagues, so the research colleagues. We had public health nursing, so they sit in children's services, and we had lots of my public health team talking about the work we're doing around food, and we did a bit of emergency planning. So public health team is tiny and our budget's minute, but what we try and do is reach into all areas of the council, and we rely on all of your support to further our agendas out into the communities that you work in, because we wouldn't reach anyone if we didn't have all of your support. And I think that's the message, Councillor Oakes, and I wanted to convey this morning, is that I'd like to thank you for your support, but also keep coming forward with ideas as to how we can reach more people around those areas of responsibility, because we're always keen to hear about them. Thank you.
Thank you, Alison. I just want to thank you for your commitment. And that when I'm sitting down at home, I hear you in my phone saying, get up, stand up now. So it's a constant thing of me thinking that I've got to move. I got a couple of questions. I'd like to start with me, if that was okay. This is a bit personal, but it is something I didn't see in the report. And I wondered if there was any, maybe I've missed it. I apologise. I've focused on, but the allergy costs. Many people have to go privately to get allergy recognition. People suffer very badly, and we know people have died from allergy. I just wondered where that sits with public health. The other thing I wanted to say was about ketamine, the use of ketamine. Very public now, very, very public in our schools. They're saying it's in our schools. I'm not certain it is, but I suspect it is. And I just wondered, I know that's the Pacific, but it seems to be very, very recognised. Excuse me, in our pharmaceutical assessments, I'm really pleased that's happening more than ever, because as you know, we suffered very badly this area with bad pharmaceuticals and getting the wrong stuff and everything else. And I also would like to ask you, the inequalities with the amount that we get, could we put a recommendation, if we can agree to the council, to actually ask why? Can something be done? Can something be sent to government to ask that? Are they not looking at why are they continually giving us? We are suffering under inequality, and I would just like if you could help me on that, please.
So just a short list, Jill.
Sorry, I apologise.
So in terms of allergy, it obviously doesn't fall within the list of our prescribed or non-prescribed responsibilities, but I will, through our work with the NHS, I will lobby and ask them about what they're doing about that. So that's the other way we work, is to identify population cohorts that have a need that we don't think their needs being met locally. So I'll look into that bit for you. Ketamine, yeah, we do actually have quite a significant problem across particularly young people. And when I say young people, I do mean school age and then going into young adulthood. We've started some work with urology, because what I've learned over the years is if you say to young people don't do drugs, it doesn't really work. But if you say to them, would you like to be incontinent at 22 and not be able to urinate without such bad pain, that generally is, yes. Yeah. So we're working with the urologists at the acute hospital, and they're going to do some videos that we've got literally people as inpatients that are already experiencing the harm of ketamine use. And I think someone said about using the voice of people with lived experience. It's no good me saying to someone, don't use drugs, I never have. But if someone who's used drugs and is living with the consequence and the pain of ketamine use, I think that will resonate. So that work is ongoing. And I think Daniel Mumby was from Somerset Live, was at one of our exec meetings, and and the BBC have helped us get those messages out. So I can share a link to that. The PNA, yeah, we've had a lot of challenges as Jahoots, one of the main providers, has, I think they've been taken over now, and I think it's allied healthcare. And I'm personally affected by that. My local pharmacy was that provider. And I don't know if I've seen a huge improvement actually in the availability. So I think hopefully we're through the worst of that. But actually, one thing that we talked about with Professor Whitty was a lot of our populations are served by dispensing practices in rural areas. And actually, they dispense your medication, but you don't have an over-the-counter service and you don't have public health advice service, and they don't do any of the round the edge stop smoking support health checks. So actually, if you're served or your constituents are served by a dispensing practice, you don't get the whole pharmacy offer. So that's something to think about. And in terms of inequalities, I would be delighted if this committee would be willing to write to the new Minister of Public Health. The last lady sadly is having her breast cancer treatment, so she stood down. So we have a new minister. So if you wanted to, it's nothing to do with the council really. We just receive our national grant from the department. So if you wanted to write to the minister and say, can you please explain why our grant is so low? We're a rural area. Then
would it be able to come from our scrutiny committee though? But would be able to, the minister to be able to say, why is our so low? Yeah. Does everybody agree that would be a good idea?
Yeah.
Could you just show of hands, please, if you think that's a good idea? Brilliant. So we'll do that. We'll put some words together. Is that okay? Perhaps with your help?
I'm happy to help. I mean, I can't promise anything.
No, but if we don't do anything, we're not doing nothing. So I'm happy to, I'd like to crack on with that, if that's okay. You can get that done in a minute, is that all right? Thank you very much. Okay, Councillor Cameron.
Oh, I beg your pardon.
I did see clear there, sorry.
Sorry. I'm not pushing in, I promise. Specific question. World Suicide Day is September, well, it was September the 6th. A Walk for Life is, you've done four or five, I think now. I'd like to set that up in the Shepton area, working with the Strawberry Line Society, Shepton Walks. Conversations are already started, and Amy Hardwick has already provided the information. We talked about it last year, but I really would like it to happen this year, and I think we need it to happen this year because we've still got rates above the average. And we can see that this work does help because you said it's heading, you're seeing numbers dropping. So what is the date? And Amy, I know, is away. And I'm hoping she comes back, but obviously she has her reasons. A bundle of joy, hope. And so here's the contact. Is it yourself, Alison? But what is the date? Because I know what happens if you don't start talking about it this time of year. It's before we know September's arrived. So, and who's looking after it at Somerset?
So thank you. So I've just done a bit of Googling and other search engines are available. So 10th of September is the day. We normally do the Walk for Life. So for those of you that haven't been involved, every year we come together as a community and we remember the people that we've lost through suicide each year. And tricky subject for me. So no, fine. So it helps people because the grief that people experience through suicide is different, and often there's a shame and stigma, and we want people to have the same opportunity to celebrate those people's lives and remember them. So we do have a lady called Alexandria Hewitt who's covering for Amy while she's nurturing her bundle of joy, and I will take back to the group your proposal around it being in Shepton. Because there's lots of different people that want it, lots of different places. So
Sorry, can I just come back? So sorry. So Amy's already took it a step forward to speak. She's spoken to Shepton Walks and myself. So it was a case of sort of just getting it firmed up. And I've got an email. So I'll send you that email to just introduce the idea that we want to do it, and we're set up.
It sounds like you know more about it than I do, Claire.
Yeah.
It's often the case.
It's Amy's good work, really.
So if we take that offline, and we will finalise where it's going to be and make sure every members are aware.
Thank you very much.
Okay, councillors, Cedric.
Edric.
Why do I keep saying that? I'm so sorry.
Cheers, Dave.
What's your name? Thank you very much for your report. And I can see the suicide thing is very, very personal too, so I won't go without that. But child obesity, I see it often in schools when I teach my bike ability in year 4, 5, and 6. And as you also mentioned healthy food or lack of maybe it's just the lack of ability for young parents these days to cook. Do you think we need to do more work in schools than with young parents at the children's centre to show people, maybe people with limited income are you accessing food banks, maybe even like the wonderful community fridge we've got in Shepton, how to knock up a simple basic meal from bits from scratch in 20 odd minutes, that sort of thing, and what work have we done around trying to get not just the children to cook, because I know most schools still do bits of cooking because it's really good for the development, but how do we work as a community with young parents who are pushed for time on children to knock up healthy meals from scratch? Because there must be some work there, because it's still more economical to do that. But those of us who were brought up in the 60s and 70s, like lots of us around this table, where we were taught to cook by our parents. I was stood over the cooker. I'm looking at a very young person over there. Did you cook at your mother's knee, Tom?
No.
Yeah, I couldn't agree with you more. I think there's challenges at every level of accessing a healthy diet. So I was in Highbridge actually, and biggest estate there, and I was having my health check, and the shop next door doesn't sell any fresh fruit or veg. It sells alcohol and crisps predominantly, and sugar.
Factory stores.
Yeah, and that is the reality for a lot of people. That how do you access it? Let alone do you know then what to do with it? So this has been the foundation of the focus on more training. So I don't know exactly how many people have been trained, but the training's open to frontline health, social care, education professionals, and it's about them having the confidence to raise weight, because weight is really stigmatized when we talk to people about their weight. A lot of us feel defensive immediately about how dare you make a judgment about me. So there is work going on, but there is always more to do. I don't know about the school's work. I'll look into that. But what we've tried to do is equip frontline staff with positive messages about food and healthy eating, so that they don't feel nervous of raising it and they've got solutions. Because if you ask people to have a conversation about someone's weight and they are a bit overweight and they feel nervous about it, if they haven't got anything to offer, they're not going to have the conversation. Tamara, who's up on that picture at the front in the grey trousers, she had Professor Whitty cooking couscous, which was an interesting experience. And couscous really affordable. You need to be a boiler kettle, and you can add loads of stuff to it, and it's nutritious. And she was cutting mint with scissors. She was saying, don't get youngsters to cut with knives. You can use scissors, and so it's making it more fun. And
well, thank you. Can I just put a word in for Bridgewater? A minute, I'm just waiting. Bridgewater, that schools in Bridgewater, juniors, and I'm sure Taunton as well, actually do teach the children about good nutritional value. But the one thing that I'm going to ask another question in a minute, but I won't. But just for Bridgewater, I must admit I've been very impressed with what's been going on there, and I believe Taunton's are doing. So I'm sure all schools are doing this as well. I really do. Now I need to move on because time is getting tight now. Okay, so Councillor Cameron.
Thank you, Chair. Tom, you'll be pleased I won't be bashing you in any way, shape, or form. We've got just comments. On the just points. Alison, as usual, a brilliant report. Thank you very much. You asked for any comments on it, and I just wondered whether once we got that wonderful diagram showing how the spend is made, is there a way of being able to associate the health outcomes that we're trying to achieve in the strategy to the spend? Don't need an answer now, but that's complex. That could be association, causation, etc. I note the paragraph about pharmacies and expansion and use of pharmacies. I've just sent you an email with regard to pharmacy blister pack waste. And I did a quick analysis and assessed that as a county, we're disposing of 33 million blister packs a year. And yet our waste core services came back to me and said that they can't get rid of and do that in a recyclable circular economy process. So I just wonder if we're commenting on our increasing use of pharmacies, etc. Surely we should be a bit more swept up on our recycling. And then the final one is with regard to the Somerset Strategic Drug and Alcohol Partnership. I note in its annual report for 22-23, it talks about the capacity areas of inpatient detox and also residual rehab. And they were looking at numbers 14, 15. But my understanding, in accordance with the National Treatment Agency, and I know that's no longer an agency, but their benchmarks were that with this cohort, 10% should be inpatients and 5% should be residuals. So we should then theoretically have something in the region of about 400 odd inpatient and residential rehab places. So I would really welcome your thoughts on that, because there seems to be a delta in capacity there and how we're going to grow that.
Okay, so we'll deal with blister packs first. If Councillor Oakes was here, fortunately, he's got the portfolio for climate and waste as well. I think he does waste and recycling. So I will take that offline and see if there's any opportunity. I thought you could recycle them if I'm honest.
You can.
Yeah. So
I just don't want to.
Okay.
Mine do. You can only do it through a certain chemist locally. So I did try to collect mine for a while, but then you have to purposely go into the town centre to go and put them in. So you can't get it through.
We'll have a look.
Yeah, more information on that.
So on to my specialist subjects, so rehab and detox. So you're right. The need and the supply don't match. The national strategy said about 2% of our treatment population should be beneficiaries of rehab. However, it's been outsourced, it's private provision, and most of our rehab provision will only take people who are entirely self-caring, because they're not registered to provide. They're registered with CQC to do rehab, but not to provide personal care. So the vast majority of our cohort of people that need rehab, or indeed detox, won't get through the front door. So what have we done about that? If we focus on detox, first of all, so that's the acute phase, if you like, of getting people through the physical addiction to whatever substance. We've been working with adult social care, actually. And one of the barriers to people having a detox is we can detox people in the community, but you can't be left alone because you might have really bad stuff. So we're putting in packages of care. We're using some of the additional government money, putting packages of care. We're right at the early days. We've got a pilot of 30, I think it is. It's very small, to see if we can make it work. And then if that can work, because we provide community detox for people that have someone at home. And I think we're doing 20-30 a quarter, quite a lot. But we could maximise that for more people who are living alone. So that solves the detox problem. And we've been working with the NHS, because what often happens is people go to hospital with an acute medical condition, get part of the way through their detox journey, and then get discharged or leave against medical advice. And then we don't have a service that can step in. So we're trying to fix that bit as well. The rehab is much harder, because this is something that there's only limited providers, and when there's a limited provider landscape, they will pick and choose which clients, and we're competing. We have one provider in North Somerset, but we don't have local providers, and so a lot of our people go to Manchester, and you lose all your support network. You don't have your protective factors around you, so a lot of people choose not to go. So this is a national thing that we're advocating for all the time. I don't know if the committee feels there's anything they can do, but there is a real gap nationally in achieving this. And then there is the debate, which is why I focus most of my efforts on detox, is does rehab really work for people? And it is massively expensive. And actually a lot of people now don't complete rehab because it's so far away from where you live and not many people can afford to, personally or financially, commit to 2 months away from life. So there's,
Yeah,
I don't know if I've answered.
That's really, I'm going to have to move on a minute, councillor, just to, Tom Power, come back to you. I'll come back to you.
Thank you, Chair. It's just touching on what Alison said about the prevention in school. So I remember I brought it up actually at executive, and it's really good to hear now that going forward, that there is, you know, people that have actually had life experience going through that, actually speaking to children about what's going on. Because when I was at school, I think we had some wacky retired actor that came in, we're sat in a drama room and he started performing some, you know, sort of barbaric acts, you know, to try and prevent us from doing drugs and sexual intercourse, whatever it was. And we just thought, well, you know, bit weird. But then having actual people that have actually lived it, going in and actually explaining to children what's actually going on is much more hard hitting. And I think that's really, really good. But also touching on, you know, what children are eating, etc. I think we need to also concentrate on what adults are eating as well. I mean, we're all busy counsellors. We're all everywhere we're going. We're constantly going from meeting to meeting. We need to make sure we're adults that are busy are also eating the right things as well. Because when we're on the road going to meetings, etc., it's quite easy to just go hop into McDonald's, you know, get a Big Mac and chips, and then go straight to your meeting, and that can become a Monday to Friday. So it's also making adults aware as well. Thank you.
Councillor Bruce. You did, you did, but maybe you changed it. Right, the question's been answered. Councillor Trimnell.
Thank you. So just want to open up where you were talking about, I know exactly that act because I remember that coming to our school as well that I worked in. And I think that, yeah, a lot of kids find a lot of this stuff very lectury. We had it when I was covering an IT lesson and the kids just wouldn't engage. And I went, come on, guys. And they went, we've just seen it all before, and they're just bored of it all. And so I think we need to find new ways, and nothing will shock you more. And I'm sure Councillor Cameron may well remember a similar thing when you join the armed forces and you have the drugs talks, and nothing will put you off drugs faster or more if you weren't ready than attending Royal Navy or probably Army drugs talk, because you wouldn't go near the stuff ever if you've been to one of those. And maybe we need to hit a little harder, I feel. So on the point of messaging, I think that the biggest challenge that we have in Somerset is that, well, I think anywhere actually, is that messaging. So you've spoken about a few things that you work on. We've got the new initiative, which is about exercise. We've had smoking, all kinds of things, drug and alcohol support. But I don't know where that messaging goes, where people see it. Is it through their GPs? If it's through social media, that comes through an algorithm. And I'm assuming that the people who live a healthy lifestyle will watch the healthy lifestyle cooking advert or read a thing about, gosh, all those people smoking, isn't that terrible? Because they don't do it. And actually the people who it should be targeted at probably brush past it. So I just don't know how to get that messaging out there. And moving on from that, those vaccinations, the fact that we've got 7.2% of 7.7% of children not having their MMR, which is a very, very large number of children. When you look at that as a percentage, it doesn't sound like much. When you put it as a number of children, that is huge. Now, my daughter had her MMR and still got mumps because no vaccination is 100% reliable, but she didn't get it too badly. But the point is, she got it from somewhere. And so if you have a vulnerable child who has been vaccinated, but they are that one that still catches something, it can be really harmful. And so again, that messaging, can we identify the children, the families who aren't opting for these like essential life-saving vaccinations, and understand why they're making those choices. Is there a demographic thing? Is it friend groups, things like that? Because we really need it of everything. That's the biggest target we have to hit.
Yes, I agree. Can I just come quickly back?
Yes.
So, in terms of messaging, went to this amazing talk and someone said, you need to see a message 7 times before you act on it. We've got I don't know how many of you are on social media, but we've got a Healthy Somerset Facebook page. And actually, if you can all follow us, because you've got lots of followers. And what we have to work on is you just have to try lots of different approaches to reaching people. So we use the radio. We've got messages going around Bridgewater at the moment on buses about breast screening. We use GP surgeries, and we have leaflets in GP surgeries, and we have, you know, in their waiting room, we have a lot of information, and sometimes on the screens. So we've been really trying to saturate our key messages out to communities, but we're probably all of a generation, and there is science behind this, not discrimination, that we are of a generation where we're information giving, but now the next generation is like attention generation. So what will land with them is what grabs their attention, not what is providing from a legitimate source. So we have to saturate all different platforms with messages that are the right messages to drown out all the unhelpful ones. And just on the vaccination, 2 things. The first is what we know, and we've done a lot of work on this in Somerset, is why are people not getting vaccinated? It's a tiny, tiny proportion are people that are opposed to vaccination. The vast majority is they just lack the means to get their child out of childcare or to a GP surgery on a Tuesday afternoon to a vaccination clinic. So we are one of the only local authority areas in the southwest and the only local authority led health visiting service that are a pilot for health visitors doing vaccinations. So we've got a cohort of 400 children who haven't had vaccinations with their GP, and we're going to remove that barrier of access to the vaccination by delivering it in their own home. And so it's really well known now that it's a tiny proportion of children or parents that are opposed to vaccination. It is just removing the practical barriers. And, you know, we absolutely will be focusing on measles because it's such a horrible disease. I've seen measles in Africa and it's hideous. You know, children die, children lose their sight. So yeah, I hope that helps reassure you.
Thank you for that, Alison. That's very, very, very. Before I move to the next, I think maybe the final speaker, I just wanted to say the one thing that I would like to see a lot more of, and something that I've been learning a lot more about because I've been involved with a lot of people who are suffering with diabetes. And I don't know, when you go online and you try to learn it, I just wonder whether we are preventing diabetes, again through food, again through knowledge, again through understanding. But I think that people are getting diabetes through some of it is genetic, I know that, but others is it just poor diet. And I think I would like to see public health do a little bit more on the diabetes if that was possible. Thank you.
Yeah, and that's all the work on food and healthy weight. We don't tend to stray into the diabetes pathways and the treatment, but it absolutely is the prevention. And we did work, Kate and the team worked really hard with the NHS about trying to get money for obesity services and weight management services. And unfortunately, they got really far through the bids, but we were unsuccessful at the final hurdle. So
the one thing I wanted to say to you as well, I remember years ago, there was a poster came out and it was the Drink and Drive campaign. I don't know if you remember it, years and years ago. And it was a girl lying on the floor and obviously she'd been killed by a car. I remember the members of the public going on about this poster. It was too gruesome, it was too bad, but it really hit home. And sometimes I haven't forgotten you, Cameron. Sometimes I believe that something like that, sometimes you have to hit home with the hard stuff, don't you? That's just a little point of view for me, but I better go to Councillor Cameron, otherwise he'd be steaming. Councillor Cameron.
Thank you. And Northern Ireland has extremely graphic drink driving adverts in their public health campaigns. I was just wondering, Chair, if we are going to write a letter to the Minister, could we also include the point around insufficient capacity around our drug and alcohol services as well?
I think it's the rehabilitation services
Yeah.
specifically, if I would be so bold, because actually they would rightly say the drug and alcohol services are responsibility to provide, which we do. And they've given us additional funding, which we're grateful for, but it is actually securing rehab bases.
I also think as well that it's better to do two separate ones.
Yeah.
I think let's go for one and then, because if we get the money, what we need, then the money can go in to help everything else. Does anybody else have anything to say more? I think we've all exacerbated this pretty good. Unless Tommy, you want to say it quickly?
Yeah.
Like 20 seconds.
I did literally. Vaccinations in schools, programs still happen?
Yeah, so we have the SAINT team, school aged immunisation nursing team, and they reach children that are attending school, but they also have an offer for children that are electively home educated and children that are persistently absent. So it's a whole system approach, and it involves GP school like roles, and so we know where children are. We have got the highest HPV vaccination rate in the Southwest. But what's really interesting is that cohort of children that have come through and benefited from the HPV vaccination rate, now in their 30s, cervical cancer rates have dropped through the floor. And that's nationally. So you can really see the benefit of HPV vaccination. And the outcome is people aren't getting cervical cancer.
Is that going to boys as well? Because when I lived in Australia, I got vaccinated for that. I went back to Bruton surgery when we moved home, and I was the only bloke on Bruton surgery that had that, and they thought that was rather strange. But now I think it's rolled out cross-national.
I can't remember which year it was rolled out, but it was rolled out to boys a couple of years ago, because obviously we tended to focus on cervical cancer, but actually boys can suffer from anogenital cancers, and this vaccine also prevents against that. So I don't know why they introduced a single gender vaccine. They said they'd never do it after rubella and the disaster that was, but they did, and now they've corrected it.
Right, thank you for that. Obviously, this report was to be note, but I think the note we want to take back is to ask for the grant, ask for a higher grant, and to be part of the public health grant. We want that to be within equality with everyone else. So Alison, what we'll do is, if you've got to go quickly after, or can I just have a word with you before you leave? That we could just sort of decide what we're going to do. Okay, so if everyone's happy with that, we're now going to, thank you, Alison, as well. It's always very, very interesting, and I really appreciate you coming, because it touches us all, doesn't it? You know? The council, so now we're going to go to the work programme, item 10, the work programme. Oh. Sorry? Oh, I beg your pardon.
You had to go.
Oh, sorry, she's had to go.
Somebody's had to go, so you can bring it forward and then again.
Can I bring it forward to the next one? Okay, thank you very, sorry about that. I'm so sorry. Everybody was sending messages saying good day. No, thank you. So we need that one on the next work programme. So the work programme we can see is the executive lead annual report. Sarah? Update on the reorganisation of stroke services, progress in implementing the homeless and rough sleeper action plan, health and social care academy training in Bridgewater. They wanted to know how that was going, what was happening. And the next one, and then tenancy strategy. So if we add the draft adults and housing workforce strategy, we can add that to the next one. One of the things I've talked to Emily about is also about Musgrove and other hospitals, but Musgrove in particular at the moment is the A&E issues that have got dramatically worse in. So we're going to bring that back. May not be able to bring it back to the May, but we are going to, I'm speaking to Andy Heron with Emily, and we're going to see what can be done. Okay. We also have said that we would bring maternity back, and you will make sure everything's running okay. That's just, we can have that as a briefing, if that, everyone's happy about that. Having that as a briefing to let us know how things are going.
Yeah.
Right? Is everybody happy with that?
Yeah.
One thing, Chair, from the minutes from the last meeting, going back to the defibrillator report, which I was pleased to make sure I came here. There is a note on there about DEM services arranging defibrillator training for members. Whether it's just this scrutiny committee or for the wider councillors, I still like to see that progress sooner rather than later, please.
Yes, well, just thank you for that. I wrote that down, defibrillators. I think what we need to do is we've said we would do it with this committee first and then be able to tell them how good it was and how worthwhile it was. Okay, Councillor Cameron.
Forgive me, Chair. Did we also make note that the South West Ambulance Service come back with their improvement plan to us?
Yes, I think they're coming back. I think I got them back in a minute. I think we said we wanted to give them a good 6 months to give them time and opportunity. So we'll put that on the list as well. Okay, thank you very much. Is everybody happy? Everybody enjoyed yourselves today?
Yes.
I'd like to thank you all, the committee. You've been really, really insightful and really full of information, and I think we've enjoyed ourselves. So thank you very, very much. I look forward to seeing you on the 10th of May. Thank you.
Chair.